Bismillah ar-Rahman ar-Rahim. Good morning. Assalamu alaikum wa rahmatullahi wa barakatuh. I hope you have enjoyed yesterday's scientific program. And today we have an extension of other aspects of respiratory obstructive airway disease. And just there is slight modification of program, which we are going to just extend the break for something like 20 minutes or so. Then in the afternoon, we'll have the live webcast by Professor David Jackson only. I would like to thank all our speakers for today ahead of time. And thank you all for attending and interacting with our speakers. We are going to leave 5 minutes after each talk for any queries and discussions. The first speaker in our session today is Professor Muhammad Al-Muammari, who is known to most people. He's a professor at the Medical College of King Saud bin Abdulaziz University of Health Sciences, and he has a major interest in bronchial asthma, and he's the editor of ATM, editor of guidelines for asthma. And his talk today is on the use of oral steroids in bronchial asthma.
Assalamu alaikum. Thank you, Professor Hajjaj, for this introduction, and thank you all for coming to this activity. It is my pleasure to talk here about this important topic. Included here, I think the screen is here, so I just will move a little bit. So included here the objectives of my talk. Okay, so the objective is to present the burden of oral corticosteroids or systemic corticosteroids in general, to present the impact of systemic corticosteroids, to highlight approach to avoid it and asthma management, and to identify patients requires referral to a specialist. We'll start with some terminology, so we'll have consensus in the way we talk. Uncontrolled asthma is the big umbrella and indicates that the patient has frequent asthma symptoms and attacks. Some patients may potentially have mild asthma that can be controlled at step 2 or 3, but because they are not adherent, they are not taking their medications, they are uncontrolled. Then difficult to treat asthma is asthma uncontrolled at step 4 or 5 based on SINA or GINA. And despite if the patient is taking adequate controller therapy, factors that could lead to that are inhaler techniques and adherence to treatment. The inhaler technique is important. Whenever I have patients in my clinic, I ask them to show me how to take 2 puffs, and you can see funny ways of taking the inhalers. So we need to spend time for the technique. Adherence, I normally ask my patients, how many times you missed inhaler last week? I don't ask them, are you adherent? I give them the fact that they are missing, so they will tell me if they are missing anything, plus looking into different comorbidities related to asthma. And when we narrow it down, we'll go to severe asthma, which is uncontrolled asthma despite maximal optimized therapy and treatment of contributory factors. Asthma that also gets worse while taking high-dose steroids. So these are the definition of asthma. Asthma is not one disease. It is an umbrella of different diseases, I would say. We call it all asthma. The differences in asthma that the way they present is different. Physiological characteristics are different, and response to therapy is different as well. The key factors for the development for asthma is that children are relatively more of homogeneous disease with a strong personal and family allergic history and atopy, while in adults it is not. It is more of a mixed disease. So this is just a general rule, but it is not a very tight rule. This is the way the concepts of asthma treatment move toward personalized therapy. In the early, in the beginning of the last century, asthma was single disease. Then recognition of asthma heterogeneity was identified, and we used to say intrinsic and extrinsic asthma. Then they thought, no, it is one disease in the 80s. Then they identified, with better understanding of pathophysiology and immunology of the disease, they start to identify Th2 disease or high Th2 disease, which is mostly eosinophilic versus non-Th2 asthma. This has led to more work on severe asthma, different projects in different countries. And lately, there are more work on genetics and phenotyping. I'm sure that has been covered during this meeting. And asthma phenotypes were more specific. So we were able to identify certain diseases. And also there are some work on non-Th2. And finally, to the treatment based on phenotype of the disease or personalized therapy. An important question is severe asthma controlled? And to label the patient uncontrolled, we need to ensure that they have poor symptoms control. We are doing that by the asthma control test, which is 5 items. Each one is 5 answers, a Likert scale, total 25. So anything less than 20 is considered partially controlled, less than 16 uncontrolled. Frequent exacerbations that requires more than 2 courses of oral or IV steroids, more than 3 days each, and serious attack whenever there is 1 hospitalization, 1 ICU stay, especially if it requires mechanical ventilation, and if the airflow limitation continues to be less than 80, FEV1 less than 80%. So this is to summarize. I think there is lag between. Yeah, so this is to summarize the asthma. So we have about 24 patients. They are uncontrolled at step 4 or 5. Then once we control the adherence and the proper treatment, we'll be left with about 17% as difficult to treat. Then we are left with about 4 to 5% real severe asthma that needs more attention. So what is the burden of asthma? Asthma is about 5% in Saudi Arabia, 5% of the population. It's expected that 5 to 10% out of those 5% have severe asthma. So this will bring us to about 0.5 to 1%. The impact of severe asthma is major on patients, emotional and mental, with the frequent visits to ER, absence from work or school. It has major impact on the patient. Symptoms, quality of life impairment, medication side effect, physical activity, and asthma attacks. One of the main reasons for uncontrolled asthma and also the use of systemic steroids is the underutilization of non-systematic corticosteroids. So patients with severe asthma will be exposed to overdose, and due to the high dose inhaled steroid and also the oral steroids and the high risk of oral corticosteroid side effects. So physicians should have clear strategies to deal with systemic corticosteroids, and that includes oral corticosteroids. A major issue in our society here is the use of intramuscular depot, long-acting steroids. It is practiced in some clinics. It gives relief to the patient for 4 to 6 months. However, it will give him all the side effects of steroids. And in SINA guidelines, we consider this is malpractice if you go to give IM depot. So what are the criteria for steroid dependence in asthma? So signs and symptoms score of asthma worsen on temporary discontinuation of steroids. The FEV1 FVC ratio, peak flow meter, and other parameters of pulmonary function test will deteriorate upon stopping oral steroids. Pulmonary function parameters and signs symptom score do not significantly improve after increasing the usual daily dose of bronchodilators and inhaled steroids. And reasonable improvement in these parameters is evident after the administration of 2 or 3 times of the previous day steroid dosage, and symptoms of steroid withdrawal will occur after stopping steroids. So these criteria tell us that the patient is dependent on steroids. So in severe asthma, they would require systemic corticosteroids that includes oral. For treatment of severe attacks, short-term use, which is oral corticosteroids, prednisolone 40 to 50 milligram per day for 5 to 7 days, or treatment of severe chronic asthma with maintenance of oral corticosteroids for more than 6 months. These are considered the definition that we'll use for short and long-term oral corticosteroids. Oral or systemic corticosteroids, they have impact on patients that includes fracture and osteoporosis, thromboembolism, hypertension, infection risk, cataract, and glaucoma, sleep disturbance, anxiety, depression, gastroesophageal reflux, diabetes mellitus, and obesity. So all these are a part of it. But without numbers, it's easy to say whatever we want. And in one study that came 2016, the British Medical Journal, they looked into adverse events associated with short-term oral steroids, 5 to 30 days, and they found that the incidence rate ratio of sepsis was 5.3. For phenothromboembolism was 3.3, and for fractures 1.9. So there is a clear association between oral steroids and these side effects. So the higher the dose, the more the complication will have. And in this meta-analysis that was released on 2016, they looked into any the risk factors developing oral steroid-related complication. So any complication, the odds ratio is about 2.2. Acute complication, again, it's about 1.5, and chronic complication is there. So there is a clear association with different complications or adverse events related to steroids. Long-term steroid is associated with 3-fold increase of adverse events for patient. In this cartoon, in this cartoon, we see the risk of developing complications. We can see that pharmacy claims will clearly increase. Inpatient visits will increase, outpatient visits, emergency room visits, and other visits. So when we prescribe it, we expect that there is increase in all these aspects. Same thing is applied for patient experience in oral corticosteroids. And when we look to different domains in this slide, we see that there is a clear association of bad experience of patient after oral corticosteroids. So patient should be evaluated and considered for alternative treatment strategies early in the course of their asthma to avoid these complications. Another study showing adverse event outcomes associated with systemic and oral corticosteroids. And you can see from the list that just think of any disease and you'll find it associated with oral steroids, osteoporosis, pneumonia, heart diseases, cardiovascular, cataract, myocardial infarction, and so on. So all these are clearly associated with asthma. The cost will increase also with the use of cost of care, healthcare increased. So in the first, so in the first, the shorter column here, for patient requiring less than 5 milligram or low dose, there is amount of, or the cost is about $2,600. When when the dose is 5 to 10, it will increase to about $4,000. And for those with more than 10 milligram, it costs about $9,000. And this means that there is an increment of about 3 to 4 folds in higher doses of oral steroids. Also, when we looked into the annual cost related to steroids adverse events, for non-asthma control, it is 132,000 euro. For moderate asthma, 167, and for severe asthma, 242. So there is a clear association between higher dose of oral steroids and side effects on the patient. In this study, okay, they looked carefully into different disease categories, and it was clear that there is the side effects will be more, and here the cost for non-asthma control $1,000, moderate asthma $1,300, and severe asthma almost doubled, 2,000 euro. So the numbers here in euro. The prevalence of using systemic corticosteroid in asthma in Italian registry, they found that 64% will use oral corticosteroids. And in another registry in UK and USA, they found 32% will use it. And this is among patients with severe asthma. So it's a common thing, common issue, common problem that we may miss or we may take it easily on patients. Just taking oral prednisolone, however, or frequent dose of IV steroids, however, it has major impact on him. And one of the issues here, when they looked into people-specific concerns about systemic corticosteroids, the first item, I worry about long-term effects of this medicine. It reached to 91%. Regular use of this medicine will weaken my bones, 80%. Regular use of medicine will make or put weight, 80%, and so on. So there is a good awareness of patient about side effects of oral steroids, and I can see it in my practice when I want to prescribe short course. Some people will feel phobia. However, in the same study, they looked into the people-specific concern about ICS or inhaled corticosteroids. We found that I worry about long-term effect of medicine on myself. It's 60%. This is high ratio. This is high number, and this needs a lot of awareness, a lot of work for our patients to correct this concern. And also that I have not received enough information about medicine. Regular use of this medicine will give me sore throat. I'm worried that I will become dependent on this medicine. Regular use of medicine will affect my voice, will put weight, and so on. So if we want to design any educational program, we need to address all these points to give our patients the correct information so they will use inhaled steroid, and this will help to use less steroid. How can we deal with patients on chronic systemic corticosteroid? First of all, we need to confirm the diagnosis and exclude other important differential diagnoses. We need to look for factors leading to controlled as uncontrolled asthma, and we keep repeating a correct inhaler technique and adherence. These are major issues in asthma. We have to check it in every patient, in every clinic, and we keep repeating. Comorbidities, we need to check it carefully. Obesity, it is common in our society, so we need to address that. GERD or gastroesophageal reflux is another common issue that we need to address it and treat it if symptomatic. Sleep apnea. In our society, rhinosinusitis is a major issue, and many patients will be controlled. They will continue to cough, will think that they have asthma. Their asthma is not controlled. However, they need treatment for their sinusitis. Any trigger factors at home or at work, medication adverse effects, anxiety, depression, and social difficulty, especially in the younger age, a younger age group. So we need to optimize asthma patients to try to stop oral corticosteroids, optimizing medication adherence, treat comorbidities, modify risk factors, and so on. And we should always try to carefully and slowly tapering oral corticosteroids for those patients on it. And I can tell you, the few patients that I managed or I received with oral corticosteroids, when I apply all these concepts, most of them will stop it or at least will give them the minimal dose. So to summarize this, watch patient using their inhalers, discuss adherence and barriers, confirm diagnosis, if possible, remove potential risk factor, assess, manage comorbidities, treatment setup, step up, and refer to specialist. And referring to specialist, when I look to the SINA guidelines, 2019, you can see it here. And we recommend step 4 and 5 to send patient to a specialist to ensure that to avoid going into taking oral corticosteroids, or if they are in oral steroids, so we can do something for them. This is what we mentioned in the text. And step 3, whenever there is difficulty in achieving control, step 3, refer to patients. Step 4, for patients who require step 4, early consideration of biologic therapy may save the patient from frequent or chronic use of oral corticosteroids. In SINA, we also mentioned the step 5, consultation with an asthma specialist is strongly recommended for this patient, and oral corticosteroid should be the last resource. Why we are saying that should be the last resource? Because now we have other alternatives. What other guidelines say? The National Health Program say that oral steroids should only be considered for the most severe, difficult to treat asthma, and minimizing oral corticosteroid and maximizing other modes of therapy is preferred. In the ARS ATS, they mentioned monitor weight, blood pressure, blood glucose, eyes, and bone density, use prophylactic measures to prevent bone density. In GINA, some patients may benefit from low-dose maintenance or oral steroids, but long-term benefit-risk ratio should be considered. Monitor patients to prevent bone loss, and primary care physicians are encouraged to refer to specialists if more than 2 courses of oral steroids per year. So there is a global understanding of the issues related to oral corticosteroid. One thing that we need to ask ourselves, patient in oral steroids, once we have controlled other factors, is the patient a candidate for biologic therapy? So we need to assess the possibility of the patient that have Th2 high asthma. We have Th2 high Th2 and non-Th2. We need to look blood eosinophils. There are different levels for different biologic agent. 150 for mepolizumab within 6 weeks, 300 in most of the biologics, 400 for the dupilumab. Fractionated nitric oxide, if you know, more than 20 indicates that there is ongoing inflammation. Sputum eosinophil level more than 2%, but this is not something that we are doing in our practice. We are using mainly the blood eosinophils. It needs a special lab setting. Asthma attacks in the past 12 months indicate that patient might be a candidate if they have severe asthma. To prevent patient with TH2 asthma could be considered, xenophilic type could be considered for anti-IL-5 therapy, mepolizumab, anti-IL-5 receptor therapy, benralizumab, and anti-IL-4, IL-13, dupilumab. More biologics in the pipeline, but we're mentioning here those which are already approved by major regulatory agencies. We need also to assist for A to B, assist for sensitization on skin testing or specific IgE, total serum IgE, assess weight and asthma attacks. We need to assess weight and IgE level because if we decide the patient will go for anti-IgE therapy, these are the factors that will determine the treatment. Patient with atopic asthma could be a candidate for omalizumab. So what is the impact of biologics on oral corticosteroids? There are different studies. I try to choose some. Omalizumab, which is the older biologic that we are using for the past 12 or 13 years, it reduced it by 50%, approximately 50%. Mepolizumab, anti-IL-5, reduced it by about 50%. Benralizumab, which is anti-IL-5 receptor antibodies, reduced it by about 70%, and dupilumab reduced it by about 70%. There is a clear benefit from biologics if the patient is a candidate to reduce it. So patient with non-type 2 inflammation could be candidate for other modalities, a trial of macrolides. This could be used, a trial for 3-4 months because of its anti-inflammatory effect, but we need to monitor the patient carefully to check if he is benefiting or not. I tried it in some patients. Sometimes it works, sometimes it doesn't. I don't have any indicator to predict it work in which type of patients. Thermoplasty, it is available in King Fahd Medical City. Dr. Hani Lamidi is here, and they are working in it. It is only available, I think, in one center, Saudi. Okay, and it needs to be more very controlled, sometimes research setting. Oral corticosteroid should be the last resource on the way to management. How to avoid oral corticosteroid? I think this is the last slide. Prior to prescribing regular oral corticosteroids, there should be full assessment on the diagnosis, inhaled corticosteroid medication, appropriateness and doses, environmental factors, comorbidities, and assess disease stability. A very good indicator is the use of more than 3 Ventolin canisters per year as indication that the patient is probably uncontrolled, more than 1 asthma attacks, assess for potential biologics. And as per CINA guidelines, oral corticosteroid again and again is the last resource. We should always look for a step-down strategy. I will not go into the details, but probably it is covered in other talks. So in conclusion, uncontrolled severe asthma is often managed with local or systemic corticosteroids. However, we need to always go for inhaled form. Oral corticosteroid is associated with increased risk of medication adverse effect. Healthcare cost is more with uncontrolled asthma. So whatever investment we do to create asthma clinics, to have proper setting for asthma patients will have a financial impact on the budget. And despite well-known adverse effects of oral corticosteroid, unfortunately, we see it used frequently in clinical practice. And we see the intramuscular depot or the long-acting still used. I consider it personal view, it's a crime to give it to patient. It's a crime to give patient intramuscular long-acting steroid. We're not talking about IV steroids for acute asthma. This is a different story because the side effects will remain with the patient for 4 to 6 months, though they feel fine, but they are developing some side effects. Thank you.
Thank you very much, Professor Mamari. And we can accommodate 1 or 2 questions. Okay. Meanwhile, just one quick one. Is it true to just, like the only justification for long-term oral steroid is if there is no access to biologic therapy? Is this a true statement? There is no access to biologic therapy?
First of all, before we have يعني for 12 years we have only anti-IgE. In the past 2-3 years we start to have other biologics. And during those days, we managed to stop corticosteroids with the steps that I mentioned here. So we managed to stop it or reduce its use. I agree with you that the new biologics will help because previously we have access to A to B. I never assist for eosinophils previously because I don't have any medication for it. But right now, biologics should help to almost exclude oral steroid, chronic use of oral steroid from asthma. We are not talking here about short course for acute asthma. We are talking about chronic use for uncontrolled severe asthma.
Okay. Question? Okay, with this, thank you very much, Professor Muhammadi. And just before going into next session, I just must say, I'm very impressed by the technology, by the setup of the presentations plate and the technology. And so I would like really to thank our partners, AstraZeneca, especially Izzat Hamza and his colleagues, for really doing very hard work to come up with this and very nice and model setup. And also I'd like to thank our technology team for excellent sound. And actually, believe it, we are now broadcasting to other countries even, not only in Saudi Arabia. So that is really good. Our next speaker is Dr. Mohammed Zaytouni, who is a senior consultant, intensivist and pulmonologist at King Faisal Specialist Hospital. And this is his talk on severe asthma as well.
Thank you, Professor Hajjaj. Thanks for the invitation. And I'm not sure if senior consultant is مدح بما يشبه الذم أم ذم بما يشبه المدح, but thanks anyway. How does this thing work? How does it? Okay. So today the theme is severe asthma. You've already heard about the problem with the oral corticosteroids or steroids in general, and it's probably important to know how we define severe asthma and when we decide that this patient in primary care or secondary care has an intrinsically severe inflammation that requires tertiary care or an asthma specialist. So over this talk, I will try to go step by step with you on the workup that you need to do, and then when you need to decide that this is time to refer to a specialist. Asthma or take care of asthmatic patients, and the majority of patients, asthma is an easy illness to be taken care of. However, sometimes it is difficult. Sometimes the patient has severe asthma. Why is severe asthma important? It accounts for around 400 million people have asthma worldwide. We still have around 250,000 deaths per year from asthma. So it is not something to be taken lightly. Asthma, severe asthma actually accounts for 5 to 10% of the population. 20 to 50% of the expenditure of healthcare goes into severe asthma, not because of only the medications, the hospitalizations, but also because of the complications, long-term complications of steroids as well that have to be taken into account. There's definitely good number of asthmatics. In this study, around 8% of asthmatics had severe asthma, persistent asthma. The cost of asthma, severe asthma is 20% in this study, but can be up to 50%. Asthmatics have triple the number of ER evaluations and triple the number of admissions to hospitals compared to population. So it is a significant problem that dealt on daily basis with lots of healthcare resources utilization. But let's define severe asthma. The terminology is important to recognize the problem. This slide is taken from the 2019 GINA update, where because of the literature had many different terminologies and it became somewhat confusing, so it's better to standardize the terminology. So nowadays, the definition of uncontrolled asthma is an asthma that is still symptomatic, or the patient is still having exacerbations. That does not necessarily mean that the asthma is severe or that the underlying inflammation is necessarily significant. It might only mean that the patient is not taking their medications or is not even taking any medication. So a mild asthmatic who is not taking inhaled steroids might be out of control, might be easy to control, but the fact on the ground, if they're still having symptoms, if they present to emergency room, like many of our patients who present and they're not taking anything for their asthma, then we cannot label that person as severe asthma. We label them as uncontrolled asthma, and that might be a problem that is easy to solve. Now, difficult to treat asthma does not mean that the patient himself or herself is difficult, but it means that the patient has an uncontrolled asthma despite the fact that the patient is on preventer medications. That could be due to many things. Maybe the patient does not have asthma, incorrect diagnosis, not using the inhaler at all, or the technique is poor, or patient has some comorbidities with the asthma that were not well addressed, and that's why the patient's asthma control is not good. Going to severe asthma, it is now defined that as an asthma that is uncontrolled despite maximum therapy, meaning step 4 or 5 treatment, while the factors that could contribute to lack of control, such as adherence, technique, comorbidities, are all addressed, and still the patient is having uncontrol. Or if you try to de-escalate the treatment, the patient will lose control from step 4 to 5. Then this tells us that the intrinsic inflammation, underlying inflammation in this patient is severe enough to be labeled as severe asthma. It's not because of any other thing. So in the past, they used to use the term refractory asthma, which gives the sense that maybe the patient is refractory to steroids, inhaled or systemic. The reality on the ground is very, very few patients are truly refractory to steroids. And it's important to recognize that to label a patient as severe asthma, all the issues that we will discuss will be taken care of. But in addition, the patient should be under the care of an asthma specialist for a period of time, preferably up to 3 months, adequate treatment, everything is taken care of, and still having lack of control. So then we can, and only then we can label the patient as severe asthma and maybe consider them for biologics or other treatments that you'll hear about in the next presentation. So it is a retrospective definition. You don't reach a definition of severe asthma from the first or second encounter with the patient. So again, lack of control could be to many things, including incorrect diagnosis, poor adherence, and inhaler technique, environmental factors that are not addressed, patients still exposed to a known allergen, or having comorbidities that are not well addressed. So to reiterate, severe asthma is an asthma in a patient who the diagnosis is definite, that is asthma, believe it or not, still up to 5 to 10% of patients referred to as severe asthma clinics don't have asthma. So you should always revisit the diagnosis every time you see a patient. Comorbidities have been treated, trigger factors taken out. I cannot tell you how many times, I think it's ridiculous to ask, but I do ask, and then it turns out that they do have a cat in the house. The patient is allergic to the cat, but cannot get rid of the cat. So in the presence of the allergen, it's very hard to control the asthma. So all these issues have been taken care of. Patient has to be compliant. Despite all these, the patient still has poor control as defined by symptoms control, having symptoms night, day, more than twice a week of symptoms, or having exacerbations. And some definitions also add having lung function that is not normal. And the patient should be on high treatment, step 4 or 5, to either to get control or not controlled despite of that. So taking the asthma population as a whole, Saudi Arabia and the Gulf, I suspect asthma prevalence is between 5 to 10%, let's say 8%. Out of these, 20% will be uncontrolled, but the majority of the uncontrolled patients are due to factors that we already spoke about that could be controlled if they're taken care of. And intrinsically severe asthma only accounts for maybe 3 to 4% of the total population of asthmatics. So what could be the reasons for poor asthma control? Wrong diagnosis or confounding illness that I'll speak about first, but we already said maybe a poor choice of inhaler, concurrent smoking, rhinosinusitis, or they mentioned by Dr. Muammari, unintentional or intentional non-adherence, and under treatment. So maybe the patient is not taking enough treatment, but that we only reach that conclusion after we exclude everything else. You tell me diagnosis, are you serious? Yes. The study from Canada, done 2 years ago, 700 patients that were, interviewed over the phone, and they were recently diagnosed with asthma. They actually had regularly a pulmonologist evaluating them, a regular lung function test, regular methacholine challenge test for up to 2 years. They stopped their medications to see if they truly are asthmatics, they will require medications. And 1/3 of these patients, 2 years of continuous follow-up and challenges, they were still asymptomatic and did not have asthma. So yes, frequently a decision that the patient has asthma is not necessarily true. Many times other presenting illnesses might have symptoms that might be attributed to asthma incorrectly. I can cite frequent rhinosinusitis, cough. Many times patients are labeled as asthma given an inhaler where the cough is coming from their upper airway cough syndrome or postnasal drip. But in that study, most of the time they noticed that if the patient did not have a pulmonary function test, no objective confirmation of an obstruction on PFTs, these are most of the patients that were mislabeled. Second, every single patient you evaluate, you should ask about smoking. Maybe smoking should be part of the vital signs. It is an important issue. Many of us fail to ask about it in all disciplines in medicine, but very important in airway disease and especially COPD and asthma patients. Smoking is an important issue because it leads actually to more severe illness. Patients who are smokers have triple the chance of being admitted to the hospital from an asthma attack. Also, we know that the underlying inflammation becomes more resistant to steroids when the patient is a smoker. So you really have to take the history, advise the patient to stop smoking. And an older person who is a smoker, you should think of maybe an alternative diagnosis such as COPD. Many COPDers are mislabeled as asthma. We see that in the community. So that's another thing to keep in mind. And always remind the patient they have to quit. Many patients claim, and appropriately so, that, I saw many doctors, they knew I was a smoker. Nobody ever told me to quit smoking. And a simple advice has a chance of being effective close to 5%. Not bad if you take the total number of smokers. This study was done on smokers and normal people. So looking at morning peak expiratory flow, a normal person giving inhaled steroid, here fluticasone, had an improvement in their peak expiratory flow on the left side. Oh, I'm sorry, it's not showing there. How do you go back? So peak expiratory flow improves in an asthmatic when given inhaled steroids, while in a smoker, asthmatic, actually, as you can see on the right-hand side, their peak expiratory flow was slightly lower. And if you look at the bottom where sputum eosinophil count was done, inhaled steroids decrease the sputum eosinophils, which is a very good marker for asthma and for the inflammation in asthma, while in smokers, it did not have any effect. So we know smoking blunts the response to inhaled steroids, and a mild asthmatic might be out of control because of smoking. Inhaler technique, this is not an issue to be taken lightly. So you have to also not only teach a patient technique, but maybe give the patient a choice what kind of inhaler they're more comfortable with. Many patients cannot, where should I point with the pointer? Which direction? Okay, maybe that direction, fine. So Patients should be trained, should be given a choice what inhaler they feel more comfortable with. But many times the trainer has a problem. Some studies were done on how staff and asking physicians to show how to use the inhaler. And many of those did not know how to use the inhaler correctly. They had some mistakes. So if you have a nurse coordinator, a nurse specialist in your clinic, somebody to teach the patient, that'd be great. But that person, whoever that is, should really know well how to use the inhaler and to teach the patient correctly. And not only that, you should actually watch the patient using the inhaler after you have taught the patient. And every time the patient comes back to clinic, please reassess the inhaler technique. Patients forget and they don't use necessarily. They tell you, yes, doctor, I have many patients. Doctor, come on. I've been using inhaler for 20 years. Yeah, you're not serious. I said, okay, take me, please show me how you use it. And still you find mistakes. So don't take this issue lightly, because the patient is not controlled. We tend to escalate, giving higher doses when the real problem is actually delivering the medications. Adherence we know is not very good in chronic illnesses in general, but more so in asthma, especially for inhaled steroids. Now this issue hopefully is not becoming as much an issue with this combination anti-inflammatory reliever medications. So we are guaranteed the patient will take both inhaled steroids and beta agonist simultaneously. So there's a delay in the response of this, so it's going. How can I go backward? Can you go backward a few slides? Yes, thank you. Unfortunately, assessing adherence is not part of the routine clinic visit. Many places, they look at the patient prescription filling from the pharmacy. In many of our government hospitals, we give the patient 3 months supply. And every time they come, they have another 3 months supply. It becomes hard to check the pharmacy records to assess adherence. You ask the patient, and that's a commonly done thing, are you taking your inhaler twice a day? And guess what the patient would say? He would say yes. Most patients feel shy to say they're not using it right. They want to please the doctor. They just say yes. But reality is different, unfortunately. Many times you really need to ask the patient in a non-threatening fashion. I ask the patients, how many times a week do you feel that you need to use an inhaler or using your inhaler? So they say, if I said 3-4 times a week, it's not bad. So many of them, they say, oh no, Dr. What do you mean weekly? I take it 3 or 4 times a week. So if you ask the patient, are you taking it twice a day? They say yes. So try to look into adherence and don't take what they say at face value. This study looked at this, that patients' claims that of adherence is 95%, but reality is closer to 50 to 60%. And if you look at if they're taking the inhaler correctly at the right time as well, this drops to less than a third of patients. There's another study that looks at patients with chronic illnesses, oncology patients, cardiovascular patients, gastrointestinal patients, neurology patients, and airway disease patients, asthma specifically. And unfortunately, asthmatics are in the lowest quartile. So within 2 to 3 months, the compliance drops to around 20%. And if you go over 1 year or more, this drops to close to 10%. So think back about your population of patients, what percentage of them tell you I'm actually compliant? Majority do. And that's why I have to quote Dr. House here, that unfortunately everybody lies, and you should not fall easily for that. Maybe for good reason, they just want to please you as a physician. Next step is to exclude an overlapping diagnosis as a primary condition accounting for the presentation of the patient. So this could be an alternative diagnosis or a complicating diagnosis. So again, as I mentioned, patients with chronic rhinosinusitis frequently present with coughing that wakes them maybe sometimes from sleep, that get to be misdiagnosed as asthma. Treated with inhalers, they don't respond for their chest. Maybe they need their nose treated better. Patients with reflux, sleep apnea patients, anemia patients presenting with dyspnea on exertion, severe anemia. Sometimes they're mislabeled as asthma or be complicated asthma, obesity, depression and anxiety, hyperventilation, episodes of shortness of breath, that come and go, sometimes responding to inhalers, sometimes not. Keep in mind, young women, sometimes even men, presenting with recurrent attacks that sounds maybe it's as asthma, but never wakes them up from sleep, more or less. No wheezing, not expected response to inhalers. Maybe they have anxiety, hyperventilation. A frequent sign you should ask for is sighing, tenheed. They feel they are not getting enough air. This is typical in these patients. But then it could be a true asthmatic with a superimposed comorbidity that is not well addressed. So you should not only address the asthma, but you should also address the comorbidity. Again, when you see that your asthmatic patient is having cough out of proportion to dyspnea, out of proportion to wheezing, you really should think that maybe this cough is not necessarily due to the asthma, because it's not concordant with the other symptoms. Maybe it's the postnasal drip, because the postnasal drip is not well addressed. Through asthmatics, up to 80% of asthmatics will have rhinitis of some sort. So you really should treat that. Gastroesophageal reflux is there. I think it's a little bit overblown. Nowadays, I hardly see any patient referred from ENT with cough, with not being on Nexium or other PPIs. So I think it's a little bit overinflated. However, you should keep it in mind. Psychological factors, again, are quite important. Not only as a misdiagnosis, but it could be a superimposed diagnosis, and these also could lead to non-adherence. These two slides to show you that patients with allergic rhinitis, superimposed of asthma with allergic rhinitis versus without allergic rhinitis, these patients are more symptomatic. They have more attacks, and they actually consume more healthcare dollars. And when you do address the allergic rhinitis, these patients have actually less attacks and less hospital admissions. Environmental factors are very important. Patients that are still being exposed to an allergen will not have their asthma controlled. So you really have to go over the home environment with the patient, especially maybe allergy testing. If the patient has house dust mite, then they have to be They have to be recommended not to have carpeting in the bedroom. They have blinds rather than curtains that can carry dust. If they have mildew in the bathroom, many issues they have to really boil or really hot water their blankets on weekly basis. What kind, I sometimes ask patients what kind of washing machine they have, because they take the hot water from the hot water source rather than boil the water. These are not good enough to kill the house dust mite and what have you. Medications, frequently quoted non-steroidals, and especially in patients in their third and fourth decade, might be an issue. But more commonly, beta blockers, especially beta blockers, eye drops. Patients, you ask them about the list of their medications, and even most, if not all, compulsive patients even, they have the whole list, but they don't consider the eye drop maybe as a medication. So you should ask them, are you on any eye drops? Eye drops with beta blockers have accounted for many deaths even because of that, but that also can lead to poor asthma control. Finally, you've addressed all these issues, you made sure of them, and none of these apply to your patient. Then and only then you should consider stepping up. Maybe the patient is not on enough controller medication for their underlying asthma inflammation. And then you increase the dose of steroids, you increase the dose of LABA, you add another controller, and follow and assess as per GINA guidelines or SINA guidelines. Every time you see the patient, as you can see in the top, you should even revisit the diagnosis. You should assess the patient, adjust their treatment if needed, and then follow up. So when should you refer, and who should you refer to a specialist in asthma? When you have a doubt about diagnosis, when you need extra help with allergy testing, you need patient. I frequently refer patients to an ENT physician for rhinoscopy, for major issues with their nose. When you suspect occupational asthma, probably this patient is better served with an asthma specialist or asthma center. When you have problem treating comorbidities, and if the patient, despite escalating, you're still having a problem controlling that patient, you believe the intrinsic inflammation is too severe, that patient might need maybe going to even biologics, then you should refer them to a specialist. And if you have a pregnant lady with asthma, maybe it's, this lady deserves to be treated by a specialist. The National Heart, Lung, Blood Institute recommends that you refer patients to a specialist when they require 2 or more courses of oral steroids per year, if they have a life-threatening asthma presentation, or if they have fixed airway obstruction, FEV1 less than 70%, despite maximum treatment. That speaks for lack of adequate control. They deserve to be treated by a specialist. Where to refer? Preferably to a person with expertise in asthma management. Usually these are pulmonologists or allergists. Better in a good center. And what should you include in your referral letter? You know, the occupation of patient, onset of symptoms, smoking, known allergies. If you did spirometry, which is very recommended, at least once at the time of diagnosis, and maybe another time once every 1 to 2 years. What medications they've been on, if they have other comorbidities, and the patient will be seen by the specialist and starting building on what you have referred for. SINA guidelines recommend referring patient in step 3. That's not controlled. Maybe you want to go to step 4. Maybe recommend for step 3. Step 4 as well is recommended. Consultation with a specialist recommended, but definitely patients who reach step 5, if they're on oral steroids, these patients should be referred to a specialist. So SINA guidelines recommend referral for, again, similar issues, uncertainty about diagnosis, difficulty achieving or maintaining the asthma control. If the patient requires immunotherapy or biologic therapy, if the patient is having acute asthma attacks that requires hospitalization, especially intensive care unit admission, and if the patient requests a second opinion. So severe asthma centers, actually, the patient is in the center of the attention. They have access to multiple specialists, and these are very important. Speech language therapists, believe it or not, is very important. Many patients have dysfunctional breathing, intermittent laryngeal obstruction that in the past used to be called vocal cord dysfunction. Nurses with expertise in asthma, ENT specialists, radiologists. Sometimes we want to do CT scans of their paranasal sinuses, rule out confounding problem of bronchiectasis or other issues. So the patient will require multiple specialties, better to be all in one center. So you bring the patient, you do multidisciplinary evaluation, and the patient is the center of all the attention, and then this is the best treatment for patients. Many times, minor issues might account for why the patient is not well controlled. Finally, in the severe asthma center, you have access also not only to personnel, but also to special evaluation of the patient's phenotyping, endotyping, and then basing therapy based on that. Biologics are available. For the occasional patients, they might need bronchial thromboplasty. And at this point, I will open the floor for questions, and Dr. Hani Lababidi will be presenting more, build up on my presentation on what goes on in the severe asthma center, how to evaluate the patient, and how to choose medications to treat that. Those very few select patients who truly have intrinsically severe inflammation causing severe asthma. Thank you.
Yeah, thank you so much. So, can I entertain a couple of questions? Yes, there is a question there. Please, microphone.
Good morning, sir. I'm Dr. Mohammad Shahid Akhtar from here. My question is, how we can differentiate exactly between COPD and bronchial asthma? What is the differentiating points?
Obviously, this is sometimes quite easy, sometimes quite difficult, and it takes a full lecture. However, in brief, obviously, patients should be older than late 30s or early 40s, who has significant smoking history, more than 20 pack years, to even consider COPD. But if a patient has onset of symptoms at younger age, if they have atopic illnesses themselves or in the family, if the patient has, say, allergic rhinitis, if the patient has, you do lung function testing sometimes, if the patient has, tremendous reversibility, very obvious. So even COPD patients will reverse sometimes with bronchodilator testing. That's why you give them bronchodilators. But if the patient has like 40% improvement after bronchodilator, this probably speaks for an asthmatic rather than a COPD. You look at carbon monoxide diffusion capacity, again, in a specialized pulmonary function testing. If it is quite low, that might suggest it is actually more of emphysematous patients, part of COPD rather than asthma. So multiple issues you take into account to finally differentiate an asthmatic from a COPD. And sometimes it's very hard to might truly have an asthmatic that smoked all his life who developed COPD, and there's an issue of asthma COPD overlap. That's why the latest GOLD guidelines open that door. If you have a patient with the current exacerbations that you think they have COPD, but there is no fill count more than 300, or they have the current exacerbations, then you might lower it to 100. Then to consider inhaled steroids even in those patients because they might have an asthmatic component.
Just I'm curious, if you have a patient with persistent symptoms, but they will let go with their cats, what do you do with them? Many encounter with this. They want their cats to keep it. What do you do?
I tell them it's very hard to extinguish the fire if you keep throwing, logs into the fire. It's very hard to extinguish. I've had patients who had their sister would never let go of the cat. So I think the only way is for the sister or the patient to get married or leave the house. You have to avoid the exposure. There's nothing. Now it depends also how bad their asthma. Now patients who truly are suffering, they end up having to make that difficult choice. But sometimes when it is mild asthma, moderate, occasionally, at least what we tell them to avoid absolutely the cat not entering their bedroom. Even if the cat enters the bedroom once a month or something, there's be enough antigen for so absolutely no way the cat to enter the bedroom. Maybe the cat should be limited to a certain part of the house, maybe outside the house, but sometimes in summer it's hard and this weather. But you have to do what the maximum you can. But eventually, I've had many patients, after an attack or two, make that tough decision. And they give it to another family that will care for the cat and allow visitation once in a while from a distance.
Okay, thank you so much, Dr. Mohammed. And to conclude our programs on bronchial asthma, we have another senior consultant, Dr. Hani Lababidi, who will talk about the algorithm for bronchial asthma. So, Dr. Hani.
السلام عليكم. بسم الله الرحمن الرحيم والحمد لله والصلاة والسلام على سيدنا محمد وعلى آله وصحبه وسلم. Can I have the slides, please? Okay. So the objectives that I put for this talk is to outline what we do when we have a patient with severe asthma, what the workup. I'll briefly describe comorbidities. I will not stress much, it has been mentioned before. And then I will report to you the algorithm that we use at King Fahd Medical City for treatment of severe asthma. As probably some of you know that we have a severe, what we call refractory asthma clinic that has been going on for the last almost now 10 years. You saw this definition. I'm not going to go again, but I highlighted one word in the definition: uncontrolled. So patients taking all these medications and still their asthma is uncontrolled. And this is the subset of difficult to treat asthma. So it is a subset of a larger population, and here the severe asthma. You saw this slide, so severe asthma is about 5%, and I want to use this slide to calculate what is the number or possible number of severe asthma here in our country, in Saudi Arabia. So if you do the math, probably about 45,000 patients with severe asthma in Saudi Arabia. So we have quite good number. And as it was mentioned in the previous lectures, these are the patients that consume the most resources medical resources for treatment of asthma. So what do we do when we have patients with severe asthma? And again, this is our protocol, and sure, it is based on scientific basis, but again, there are sometimes there is an art more than science in certain things. But number one, what we do is we confirm the diagnosis. Even if the patient is referred from a very famous center, we again try to confirm the diagnosis of asthma. Simple thing to confirm the diagnosis, spirometry. Please remember spirometry. It is a simple test that can give you a lot of information. So this is a spirometry of one of our patients, and you see that the patient has low, the ratio is reduced, FEV1 over vital capacity, and the FEV1 is reduced, and there is good response to bronchodilators. If you look at the spirometry curve or the flow volume loop, the red one is after giving bronchodilator, the blue one is before. So clearly there is an improvement. This is asthma, no question about it. So this is clear case of asthma, especially if the patient is non-smoker, patient is young, so this is asthma. So we try to confirm diagnosis as much as possible. This is another case of asthma. Again, if you don't want to look at the numbers, just look at the curves. There's improvement from the blue to red lines, and this is also indicates that this patient has asthma. So number one, we need to confirm the diagnosis. What about the patients who has fixed obstruction or they don't show this kind of improvement? We go to methacillin challenge test and we say, wow, do you challenge patients with severe asthma? Why not? If patients have normal spirometry and you don't document changes after bronchodilators, I need to know that this patient really has asthma and nothing else. And I will give you an example later on of a case where her methacillin was negative and we had to go to bronchoscopy to make the diagnosis. Later on, I will talk about this. So what we do with methacillin, we challenge the patient. We give methacillin to a patient with asthma, and we see if there is a drop of an FEV1 by more than 20%. Sure, you cannot do this in a clinic or in an office. It has to be done in a well-controlled environment, pulmonary function test, and usually a physician is available when this test is done. Because if the patient develops asthma attack, you need to know what to do and how to treat this patient. So this is an example of the patient that I will mention later. Her methacillin challenge test was flat. We gave her methacillin, and if she has hyperactive airway, if she has asthma, she has to drop her FEV1. She didn't drop her FEV1. So after we confirm the diagnosis, we'll immediately go to asthma education. We believe in asthma education. So treatment for asthma for us is education, 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 and then medication. When we talk about asthma education, we look at comorbidities. And I put here some of the comorbidities that we look for in our patients in the severe asthma clinic or refractory asthma. Now, remember that these comorbidities may influence the response to treatment. So you need to identify them and try to solve these comorbidities or improve them as much as possible. So every effort should be done to control the impact of these comorbidities. At least you remove these factors from your way when you treat patients with severe asthma. Now, remember that evidence that this will improve the course of the patient asthma is not that big. So we don't have very good scientific evidence that controlling comorbidities will improve asthma dramatically. It will have some control in asthma, but it will not solve the patient's problems. But we need to look for them. So what are the things that we look at? It was mentioned before that rhinosinusitis is a really common thing that we see here in Saudi Arabia. So look for allergic rhinitis, look for sinusitis, and if there is any evidence, you need to treat. Look for nasal polyps. And now we talk about biologics, and there is effect on biologics on nasal polyps. So look for these comorbidities. If you don't treat the nose, you will not be able to really control patients' condition with the severe asthma. We always talk about reflux, and sometimes we go the whole 9 yards of treating the reflux symptoms. Now, if there is reflux, treat. If there is no reflux, there is no indication that empirical treatment is of any value to patients with asthma. So empirical treatment with PPI for asthma should be out. And this has been documented, and now there's no question about it. If there is evidence of GERD, either symptomatic or sometimes we go with endoscopy, then you have to treat with PPIs. Smoking is a risk factor. Sometimes we think smoking and asthma, they don't coexist. No, they do. Some of our asthmatics, they do smoke. Now, there is an association between smoking and fatal asthma. So every effort should be made to advise and counsel patients to stop smoking. Smoking cessation will improve their symptoms. Sure, it will not abolish asthma, but it will improve their symptoms. If the patient has obstructive sleep apnea, he needs to be treated, and basically two symptoms will be improved: the choking sensation and nocturnal choking. Also, this will be improved. Dyspnea when you treat OSA. Anxiety and depression for sure, and many times we see this in our refractory asthma. Severe asthma is a really very bad disease and very debilitating for some, especially if the patient is a working individual. So they get depressed, and you need to treat this as well. What about obesity? This is a common thing in our population, by the way, obesity and asthma. Now, this is one of the studies where 33 patients, obese patients, they went into weight reduction, and their symptoms got much better. Sometimes we have to refer them even for bariatric surgery. I have 6 patients in my clinic whom I refer to bariatric surgery, and their asthma got better. Again, you don't abolish asthma by treating obesity, but at least you can get better control of their symptoms. Good. Then we go with asthma medications, and I will not go in details about what asthma medications that you need to use, but sure, inhaled steroids, LABA, and so on. Then we ask ourselves this question: are we achieving control of patients' symptoms? If yes, fine. So continue educating, controlling comorbidities, and the medications that patients are receiving. And this has been covered in a previous lecture. If no, then the question comes to what workup I need to do in order to really diagnose this patient with severe asthma. A common thing that we do is CT of chest. We do also blood tests. Among these blood tests is ANCA and ANA. And the reason why, because some of these patients, they don't have really asthma. And this is an example of a patient that have Churg-Strauss or EGPA, eosinophilic granulomatosis with polyangiitis. They present exactly like patient with asthma: wheezing, eosinophilia, sinusitis, but also some of them, they have more symptoms like neuropathy. And it is a vasculitis of a small and medium vessel disease. Usually on CT scan, you see these small dots, and some of them you need to do a biopsy. Now, the criteria for diagnosis, you need more than 4 of these 6 criteria to diagnose EGPA or Churg-Strauss. In our clinic, I have diagnosed 3 patients who were referred to me for thermoplasty, bronchial thermoplasty, and out of this, like almost 10 years now, I have 3 patients with EGPA, and they are under treatment with biologics, and they're doing great. This is the patient that I told you about the methacholine challenge test. Her methacholine challenge test was normal. She's been on inhaled steroids for many, many years, and she's not doing better at all. And this is a condition, what we call excessive dynamic airway collapse. Look at the slide on your left. Her posterior wall of the trachea almost collapsed the whole airway. And patients present with wheezing usually. But this is not asthma. And you cannot treat this patient with inhaled steroids. They don't do any good. The treatment here is you can give CPAP or like a non-invasive during night. And some of these patients, they go for stenting of their airways. It's a difficult condition to treat. Okay, so after we do this lengthy and expensive kind of workup for these patients to rule out other conditions, including also CT of sinuses and so on, we come to what we call phenotyping of patients with severe asthma. Now we talk about phenotype. So what is the phenotype and what's endotype? So the phenotype is the constellation of symptoms and information that we can gather about this condition, and we call it as a phenotype. While an endotype is a specific chemical or test that the patient has, and I can call this patient has this endotype. So phenotype covers more than just endotype. And for asthma, you've been hearing now at Th2 high and Th2 low phenotyping. The terminology now about eosinophilic and allergic asthma, the Th2 high, and the new biologics for these conditions. Now I'm going to take you to one of the studies that we published just about 1 month ago. And this study, what we looked at all our patients with refractory asthma in our clinic, and we checked their IgE and their eosinophil level. So it is a real life study. These are real patients. At that time, we had around 240 patients attending our severe asthma clinic. We only included 142 because we wanted to have their spirometry, their IgE, their ACT test, and their eosinophil count done within 1 month. So we had this number. 32 patients had normal IgE and eosinophil count, and the rest have high IgE and eosinophil count. Now, we had more females than males, and females had higher BMI. Obesity was higher, so 32, the BMI, and their control of asthma was lower than males. And by the way, this is true for in other studies about severe asthma. Always females are about 3/4 of the population. So females are more prone to have severe asthma than males. Now, this is the scatter diagram for the association between IgE and the eosinophil count. And these are the characteristics of the patients. Again, females are about 3/4. Average age is 43, so young population. The average IgE in the patient with high is about 500. The eosinophil count is again 560. BMI total between females and males is 31. They are not controlled, and this is by the asthma control test, 13. If you remember, 13 is not a good number. That means they are not controlled. And their FEV1 is about 70% with the ratio of about 71%. This is the characteristic of these patients. If you look at between high and low IgE and eosinophils, they're comparable. The only thing is the patients with high IgE and eosinophils, they have lower FEV1. So their pulmonary function tests are worse. This is the scatter diagram. if we want to put certain level, and this is the most important one that I want to spend some time on. So if you look at this, we categorize these patients into 4 categories. Category 1 is where you have a low IgE and a low eosinophil count. Category B, where you have a high IgE and eosinophil count is below 300. Those with eosinophil count high but low IgE is C. And most of our patients, about 60%, have both IgE high and eosinophil high. And this is important for phenotyping, because in phenotyping, you want to know which is driving the severe asthma. Is it allergic, the IgE, or eosinophilic, and then you treat as eosinophilic asthma. But in real life, they overlap. So 60% you have overlap, and this is the challenge of what to treat, what medication to use in these patients. So this is where we have a decision point in our clinic for these patients, is we look at the IgE and the eosinophil count. The IgE is driving, it's easy. Then we have the Xolair, omalizumab we use. If both are high, then we have more than one option. So this is where we look at the different phenotypes in our population, in our clinic. Now, we have medications that can be used, and basically the medications that are available now in Saudi Arabia, anti-interleukin 5, mepolizumab, and we have interleukin 4 and 13, which is dupilumab. Now, benralizumab, Benra is interleukin 5 receptor, is not registered yet in Saudi Arabia, but it will be soon available, probably within 2 to 3 months. I put these medications, these are the available medications now that has been approved worldwide for asthma. If you start on your left side, you have omalizumab, Xolair, and has been there for more than probably 15 years. We've been using anti-IgE. The second one from your left side is Dresli, but I'm not gonna discuss it because it won't be available in our market. It's not available in the markets here, and it is given IV. The first biologics, the new biologic has been approved was dupilumab, and it's anti-interleukin 5. The Benra next to it is the interleukin 5 receptor, and as I mentioned, it's not yet approved in Saudi Arabia. And lately, the Dupi, which is anti-interleukin 4 and 13 R receptor, has been also approved. I put down the exacerbation rate, how much reduction of exacerbation rate for these medications. Okay. I don't know. And if you can see here, like with Xolair, studies, Innovate study about 25%. However, the new biologics is about 50%, plus or minus, okay? Now, I know that this comparison is not accurate because it's not a head-to-head comparison. It is not just the report, what they reported. So the inclusion criteria for each study is different, but still, it can give you an idea. They run at the same rate of reduction. The FEV1 change, there is improvement in FEV1. Now, the most new one, Dupi, is the highest with 320. The rest is 100 to 190 improvement. And I put last is the approval status, so Xolair available, and Dupi, Mepo is available. Benra is still not. It is available in US and in Europe, and Dupi now is available in Saudi Arabia as well. This is just to look at the most recent 3, and I added to it is the reduction in oral steroids. We listened to Dr. Muammari, and he mentioned how bad oral steroids are to our population. So we need to make every effort to spare these oral steroids and not give our patients to oral steroids. Now, if you give more than 2 courses of oral steroids per year, then automatically this patient has severe asthma. This is the new guidelines now. So this is where the good thing about the biologics and the importance of using biologics, although they are very expensive, but they are very effective. And the reduction of more than 50% reduction in the dose of OCS, you can see it is between 45 to almost 60%. And if patients using less than 5 milligram, you see them also 50 to 60 plus %. So they are very effective in controlling severe asthma and sparing steroids. And many patients with oral steroids, we were able to go to low doses with these medications. Okay, now, if we've done everything, yes. Yeah. Then we have these choices. So we do phenotyping, and we decide if it is mainly IgE, we give omalizumab, okay? So we do skin testing or RAST. Eosinophil low, then we give omalizumab. Otherwise, you have choices, okay? And until now, you cannot say this is better than this one or not. Although now there are more studies about patients on oral steroids or with the nasal polyps, but all of them, they will work on these conditions. If the patient has got better, fine. If not, then the last choice that now I have in my clinic is bronchial thermoplasty. Now, before we do go with bronchial thermoplasty, we do bronchoscopic phenotyping. And this is done in a few centers around the world. We're one of these centers, probably 5 centers around the world, they do bronchoscopic phenotyping. And what we mean by bronchoscopic phenotyping, we take the patient with severe asthma to the bronchoscopy suite and do bronchoscopes, and we take biopsies. We take BAL, we take cell count cultures and PCRs. We do the bronchial biopsy, and we mainly look if is it eosinophilic predominance, neutrophilic, or mixed. And we look at the muscle mass in these biopsies. So this is our data from our phenotypic patients. We have about 35 patients who underwent bronchoscopy for phenotyping, and about 42% eosinophilic, 23% neutrophilic, and then the rest are mixed cellularity. And for the muscle hypertrophy, most of them, they have muscle hypertrophy, 82%. Those with muscle hypertrophy, moderate or severe, we propose for them or suggest for them to go for thermoplasty. But remember, these, if they fail all other treatment, including the biologics. These are some of the examples for our biopsies. And if you look at this, the pink color are the muscles in the airway, and you can see them hypertrophied, and they are thick. And the where the arrow is the muscle, smooth muscles that we attack during bronchial thermoplasty. Now, what's bronchial thermoplasty? This is in the left side is the normal airway. The right side is a cartoon of the patient with severe asthma, and you see the muscle mass is really thick. So we use, with the bronchoscope, we introduce a small catheter, and it has a basket on the end, and it delivers heat to the airway, and kind of this smooth muscle will atrophy, and patient will have better improvement in their symptoms. So this is what we call bronchial thermoplasty. It is a lengthy procedure. Each procedure takes an hour and a half. And patient with severe asthma who will undergo thermoplasty, we do 3 sessions. Each sessions are 2 or 3 weeks apart. First, we go for the right lower lobe, then we go to the left lower lobe, and the third session, we do the upper lobes. Plus, in our protocol, we do phenotyping bronchoscopic. So total of 4 bronchoscopies for these patients. It's a lengthy procedures, very costly, but sometimes we have to do it, and there is good response to bronchial thermoplasty if other modalities failed. So in conclusion, now we have personalized treatment for patients with severe asthma, and we need really to work these patients very well and rule out other conditions. And if patients fit, then we need to give them this personalized medicine. And specialized refractory asthma clinic is essential in treating severe asthma. So you cannot treat them in any clinic. You need to have a team, and Dr. Zaitouni mentioned the large team that we use in order to treat these patients. Thank you very much.
Sir, good morning. I am Dr. Akhtar. My question is, what are the side effects of thermoplasty, that is bronchial thermoplasty, side effects?
Okay. So the question is, what are the side effects of thermoplasty? Now, this is a bronchoscopy, so it's an invasive procedure. And you know, these are patients with asthma. So one of the side effects is having asthma attacks. But there are protocols that we use that you give patients 3 days of oral steroids, plus we give nebulized Ventolin immediately before, or albuterol, immediately before the procedure, and many times also after the procedure. So basically, very minimal side effect accordingly. So if you do it in a controlled environment, very minimal. But has been reported respiratory failure, even death has been reported with bronchial thermoplasty. We have, alhamdulillah, Rabbil Alamin, over the last 8 years, we didn't have any problems with this procedure.
Okay, question over there.
Thank you, Professor. What is your, the post-thermoplasty, the maintenance, the remission? What is your experience in your center? And then what you do with the medication, reduction of all those medication?
Okay. Now, the first question is remission rate after thermoplasty. So if you take 100 patients who undergo thermoplasty, you can easily divide them into 3 categories. 1/3 will get better. It is like magic for them. 1/3, as if nothing happened to them. And there's another 1/3 who get improvement in their quality of life. Okay. Now, usually this improvement is limited between 3 to 5 years. So I have 2 patients who I had to do another thermoplasty after 4 years because the smooth muscle will hypertrophy again and so on. Now, after the initiation or the availability of the biologics, my business of thermoplasty is going really low. So like this year, I have only 2 cases. I used to do like 8 to 10 cases a year. And I think thermoplasty will not last for a long time with these biologics because these biologics are very, very effective. They make wonders to these patients.
Okay, talking about biologists, is there any chance for giving another one if one failed, or a combination of 2 or 3?
Now, what we have in our market, we have 3, like sure, omalizumab, but for the new biologics in the past 3 years, we have the anti-interleukin 5 and anti-interleukin 4 and 13. Now, the failure rate with interleukin 5, which has been initially present in the market now, the first one present in the market is about 80%. Now, I have so far around 40 plus, 45 patients on interleukin 5, and I have 4 failures. Now, 2 of them has been switched to the interleukin 4 and 13. Yes, there is a you can switch to another, but I wouldn't switch from interleukin 5 to interleukin 5 receptor because it is almost the same mode of action.
Has anybody tried combination of 2?
Okay, this is the $1 million question. So the question of Dr. Al-Hajjaj is there a role for a combination therapy? Until now, no, and it's a big no. Because, these medications are very, very expensive. So one injection of these biologics depends how much they get it, if it is in a big center or like Ministry of Health and so on. But we're talking about 3,500 riyals every 2 weeks or every month to 5,000 every week or every 2 weeks or every month. So they are very expensive. To combine both, so we're talking about 7,000 to 8,000 riyals per month, which is not that. But in the future, anything can possible. But for now, it is a big no.
Thank you very much, Dr. Hani, and for a very interesting talk. Okay, we're just going to complete the discussions on bronchial asthma. And there is no complete program without talking about macrolides. Is there a rule of macrolides, especially in severe asthma? Can you get the first slide, please? Okay, so this is macrolides is a big topic. So I'm going to choose only azithromycin, or azithromycin, where most of the study on, and bronchial asthma again. I'm going to choose the severe asthma. So it is long term, not a short term azithromycin, and for uncontrolled asthma or severe asthma. Seem to be okay. So again, there have been slides on studies on mostly azithromycin, some on clarithromycin. However, azithromycin is the one which got most of the studies. And it seemed to be that it does have some useful effect, which we will discuss a bit later. Okay. So macrolides. I'm having difficulty in seeing the slides there or there. So anyway, you can use macrolides for short-term therapy, which is common. We always use for like 3 days for azithromycin or 1 week for clarithromycin. But this is not the one we are going to talk about. We are, and again, it can be used for other things like pneumonias and all this. But we are going to talk on the other side, which is steroid for severe asthma. However, for respiratory diseases, we know that even long-term macrolides, particularly azithromycin, have been used for bronchiectasis and COPD as well. So as we are talking about personalized medicine, the problem is if you go through the guidelines and the stepwise approach, you barely see any mention of macrolides or use of macrolides for at the end of the track. So this is something which hasn't been established until recently. That's why it's not in the guidelines very much clarified. I think with updates of new guidelines, you probably see some more space for use of long-term. We're talking about long-term of steroids. So in the GINA guidelines, it was mentioned in the algorithm, and if I can point somewhere. So it is mentioned in the algorithm. You can see there. However, as like a last resort, and we will talk about what are the indications in the coming slides. This is the CIRA guidelines. And again, there is not, I see at the very end, there is it said other therapies. However, in the text, it was mentioned that macrolides have a role in patients with severe asthma, but not every patient. We will find out. So I'll just go through the literature, and you can see this, the study, the macrolides of the long-term management of, this is a meta-analysis, which actually didn't give a very good conclusion at that time. Said significant improvement in peak expiratory flow and symptoms, quality of life, and airway hyperactivity. But we are really interested in what? We are interested in exacerbations. So if anything, any drug that will reduce asthma exacerbation, which means that patients coming to the emergency room may or may not need admission. However, this is a frequent, if anything that will make good impact on exacerbation, this is what we want. This meta-analysis will showed some benefits, however, but not really what we want. Let us see some more literature. A Cochrane systemic review in September 2015 has, as you can see, they reviewed a lot of studies, and they didn't come up with really good conclusions. However, they say they may have some benefits on symptoms, again, but not much of exacerbation. So until that stage, we are not sure whether there is really good use, because you're not going to give azithromycin for 3 days or 1 week. You're going to give it for 6 months. Until we get these two, I would say, breakthrough studies, as the SAST and AMAZES. We'll go through them. So you can see this was published showing azithromycin for prevention of exacerbation in severe asthma, a multicenter randomized study. This was published in Thorax by Brussels and his colleagues. It took 26 weeks, and they use a smaller dose than the next study, 250 milligram, 3 times a week, and only on 100 patients, or on 109 patients. So they show a significant improvement was noted on asthma quality of life questionnaire, which is just symptoms. However, not much, if you can see here, not much on exacerbation. So this is, until now, they thought maybe we haven't done anything good, until they did split study, and those patients with allergic asthma or eosinophilic asthma, and it does show improvement. Then that was the benefit of the study. In 2017, effective azithromycin on asthma exacerbation, the AMAZES study was published, and this is the one which actually would put the indication for giving long-term azithromycin for these patients. So as you can see here, this is all exacerbations, different types of forms of exacerbations. These graphs talk about the same. However, this will, and they show significant improvement of exacerbations. That is what we really want. So, and not only this, but you can, if you look at the other tables, this is also shown on they have less problems with use of other antibiotics and infections, respiratory infections. So it has other benefits. So at this stage, maybe just those who are not following or a bit sleepy at the end of the day, I would just would put this question. What do you think about it? What's the most common, since we will consider using long-term, and we're not talking about 3 days or 1 week, or long-term use of azithromycin, what do you think the most common side effects? Anybody will go with the skin allergy? The most common, they all these side effects probably, but what is the most common? Anybody with skin allergy? Palpitations? Not sure. Diarrhea, hyperuricemia, and hepatotoxicity. So just pause a minute to think about them. And in fact, okay, this will come in the other studies. I am not very expert on pathogenesis and this mechanism. However, this is how long-term azithromycin works. It doesn't seem to have more than just antibacterial effect. It has a lot of other anti-inflammatory effect, also maybe antiviral effect, and other immunomodulation effect or modification effect. So in the beginning, it will clearly inhibit the bacterial growth if there is, which could be existing in the respiratory tract of asthmatic patients. And with time, after you continue giving steroid, they will change their rule from just being antibacterial, because there will be probably no more bacterial presence in the respiratory tract. Then it will start giving enhanced generation of modulated autophagy and other immunomodulation. That is the way they reduce the exacerbations and patients coming to the emergency room every now and then. However, the problem with all antibiotics, especially if you give them frequently or repeatedly or long term, is resistance. And this is we have to really be worried about and be careful about, because that's, especially if the patient would stop and take it again, which is going to be somehow a problem. Anyway, this is, for example, this is an example, I think this is in China, it's very high exacerbation rate. So really, you have to be watching this. Adverse effects, as the MCQs goes, it is actually diarrhea is the most common, which is manageable. You don't stop the drug because of that. So now, since you are going to give long-term, you have to be worried about the patients with renal problems and patients with hepatic problems. So you have to be careful. Maybe you do want to choose it if they really are, or you have to really get a good watch on the patients, because it is eliminated hepatically, and also if the GFR is borderline, you have to be really careful and monitor the patient. So what are the contraindications? Hypersensitivity, history of problems, liver problems, heart problems, and patients with cardiac arrhythmia. So these are the ones you have to be careful on. So try to give them to a patient who is not having these problems. Otherwise, you may get into it. For pregnancy, and breastfeeding, there is no direct effect. However, you better to avoid breastfeeding at that stage. So this is my conclusion, is that now there is a rule for long-term use of steroid of azithromycin for asthma exacerbations for those patients, not every patient, but a limited number of patients, and try to find the best fit of your patients. So azithromycin is effective in preventing asthma exacerbations when this is the condition, when you tried inhalers do not work, or still with these inhalers, of course, the patients still have exacerbation, which qualify for severe asthma. Of course, in this stage, we use biologic therapy, as you all heard along. However, there's also room for azithromycin. If the biologic therapy works, that's fine. We don't need to, because azithromycin is antibiotic, it has some problems. biologics are more effective. And then, however, there are patients either do not have access to a biologic, or they may have problems with side effects, and you cannot use the biologics, or so there is a room for azithromycin. So the benefits are definitely for symptoms, quality of life, asthma control, and definitely exacerbation, improve PFT. So there is impact on these type of patients. However, benefit is mediated by preventing respiratory infections, enhancing viral activation, other inflammatory effects, but should be reserved, as I said, for patients who at highest risk of exacerbations, are restricted to months of autumn and winter where there is more, exacerbations at this, because, the flu season and all this, the many more exacerbations. So you try not to give the patients more than they need. Best use for patients with exacerbation, patients not candidate for biologics. There we have, not everybody is suitable, or maybe they have side effects. And especially for neutrophilic asthma, where it may have been mediated, or mediated by bacterial or infections rather than allergic or eosinophilic effect. So this is probably a better, although it's not very much limited, there is a room for other patients. The dose is 250 to 500, 3 times per week. So we prefer the 500, however, for like small weight or there's worry about side effects with borderline kidney function, liver function, you may want to use the lower dose. The duration is 48 weeks. What do you think this is? What do you think this? Okay, actually, these are all the brand names of azithromycin around the world, which means it's very popular drug, available, not like the biologics. So this is something you may want to, you may choose if you have faced with a patient who have intractable severe asthma. That's all I want to say, and thank you very much, everybody. Thank you. Now we will have a break, and we will come back at 1:15. So we'll see you again. Thank you very much for your attention. Assalamu alaikum wa rahmatullahi wa barakatuh.
very long time in CF, and it's proven to be effective in a neutrophilic inflammation. CF,
Yes.
COPD are neutrophilic,
Yes.
and the last study was in neutrophilic severe asthmatics was proven to not the eosinophilic.
Feel, to decide to go for this or not.
Thank you.
From the state, from my London, we're talking about the treatment of asthma. Can join.
تست سمعنا انت
سمعك فاصلة؟
لحظة تمام رياض تيست. تمام رياض تيست. تمام رياض. تمام رياض تيست 1 2 3. احمد. تيست. تمام رياض تيست. واصل صوتي اوكي.
Test mic.
اوكي تمام اوكي رياض.
Okay, done.
ثانك يو ثانك يو. يلا اوكي.
Test Gadda test. Test.
دمام دمام جدة تست تست دمام تست تست دمام جدة تست تست
تيست. تمام معك.
تمام صوت واصل.
اوكي الصورة
الصورة تمام.
تمام.
رياض come up.
تمام. جدة تمام.
الدمام معاك.
دمام سمع جدة.
سامعينك تمام.
احكي يا محمد علي.
جدة لسه ما طلعتش.
محمد علي
ايوه
احكي يا شعبان. دمام
دمام معاك.
احكي. جدة احكي.
محمد علي معايا. جدة.
رياض احمد.
سمعك.
سامعينك يا محمد علي.
يا جيمي انت على الهوا يا جيمي. بطل حركة. اثبت بالكاميرا.
تمام
كبر الصورة. اوكي يا ريت تمام اوكي.
لاست تيست. جدة دمام.
جدة
أوكي.
تمام.
دمام.
دمام معاك.
تمام.
تمام هنا.
Last jet. Last test. جدة.
دمام تيست.
الدمام تمام.
دمام معاك.
جدة سامعيني؟
دمام
تمام.
سمع.
اوكي دمام ممتاز. جدة.
جدة تمام.
جدة اوكي.
اوكي.
اوكي حبيبي يلا. Ladies and gentlemen, in few seconds our presentation will present. Okay, thank you very much.
Okay, Bismillah ar-Rahman ar-Rahim. We'll resume our sessions this afternoon with Dr. David Jackson. And I want to, first of all, thank him so much because he took the struggle to come all the way from UK here, despite his very busy schedule. And Dr. David Jackson is a consultant respiratory physician at Guy's Hospital and St. Thomas NHS Trust, and he's the leader at the severe asthma clinic, or unit actually. And so he has a lot of experience with what we want to know here and our theme of this scientific program. He is also leading great research in the topic, especially on virus-induced bronchial asthma and exacerbations that we already, alluded to. But I'm sure he will enlighten us on all aspects of this part. So he will talk about treatment of asthma with monoclonal antibodies. And I would like to welcome him to the stage. Only show on the screen. This is forward.
Good afternoon. Apologies for being a little bit late. My flight was delayed. One of the issues of flying from the West is, although it says you land at 7 o'clock in the morning, in my head it's still 3 o'clock in the morning. So, but I'm delighted to be here, my first time in Saudi Arabia, so many thanks for the invitation to your beautiful country. Now, over the next hour or so, I want to discuss several aspects of asthma care, which have become increasingly important over the last 10 years or so. As our understanding of asthma has improved, we now have these new therapies. And I think it's important to really understand some of those mechanisms so that it allows you to choose the right treatments for the right patient, and also make sure you're not actually doing the patient's harm. Because unless you identify that a patient, for example, has a certain type of inflammation, then steroids don't work, and all the patient has is the side effect. So understanding asthma in many levels is really, really important. And today, I'm going to first talk about the importance of differentiating difficult asthma from severe asthma. I'm going to talk about this concept of doing no harm to our patients first, and using biomarkers of inflammation to help guide you. We're going to talk about severe asthma phenotypes and which patients should be referred to asthma specialists, and the biologic therapies that we now have available to us. So what do we mean by difficult asthma and severe asthma? Well, if we think about the patients that come to our clinics, they are patients who are symptomatic with breathlessness and chest tightness, the common symptoms of asthma, despite already being given a high-dose inhaled steroid and beta agonist, okay? If they're fine, if they don't have symptoms on this therapy, then it's fine. But the patients we get sent are these patients. Now, many of them will have symptoms due to asthma. But many of them, although they have asthma, their symptoms are due to other things. And in many cases, although they've been told many years ago, 20 years ago, someone said they have asthma, when you actually look properly, they don't have asthma. And so the patients that you see who have got these symptoms despite being given the inhaler always fall into one of these three categories. Now, there's many reasons why a patient with asthma or without asthma can be symptomatic, and the symptoms similar to asthma. This is not an exhaustive list. This is the most common comorbidities we see in our clinic: dysfunctional breathing pattern, VCD or inducible laryngeal obstruction, bad reflux. You know, patients don't always say they have heartburn. Sometimes it's just a cough at night, and someone says, oh, it's asthma, and actually it's just really bad reflux. Being deconditioned and obese. You know, walking up a flight of stairs, if you're very obese, that's enough to make someone breathless. It's not because of their asthma, it's because of their weight. and many other conditions as well, especially large airway collapse, which is often very difficult to diagnose. Now, this was a study done 2 years ago in Canada. And what it showed really was that in a third of cases, the diagnosis of asthma was wrong. When they really went back and had a look, and it wasn't just, primary care physicians making an error, it was secondary care physicians. Actually, a third of the asthmatics, almost, the misdiagnosis was made in secondary care, either by a pediatrician or an allergist or a physician, internist. So it's something that we really need to be aware of. The number one question when you see a patient who's still symptomatic, despite treatment, is maybe it's because they don't have asthma. Maybe they're not responding because they don't have asthma symptoms to respond to. We see tracheobronchomalacia quite often now, which has never been picked up. Sometimes you can see it on a CT scan if you do inspiratory and expiratory images, but often you need a bronchoscopy to see it. Often it's very, very difficult, but the symptoms don't respond to salbutamol. They don't respond to prednisolone. We see this condition called inducible laryngeal obstruction, where their symptoms really are at the level of the larynx. Often when the patient comes into the room, you can hear the wheeze even before they sit down. You don't need the stethoscope. Often those patients have wheeze up here, it's coming from the throat. And understanding that it might be something here rather than here is really, really important. Again, this does not respond to asthma treatment. Very typically in this is exercise induced. There's many other triggers as well. Sometimes it's very strong perfumes or strong smells that can cause it to close down. But this happens very quickly and gets better quickly. But it doesn't get better with salbutamol. Asthma symptoms come on gradually. They don't, 1 minute you're fine, the next minute you've dropped off a cliff. Asthma is not really like that. Anaphylaxis is like that. Inducible laryngeal obstruction is like that. But asthma, the symptoms build up over days usually. You catch a virus, goes to the chest. It's a period of days. Now, the most common reason why patients have symptoms due to asthma is either it's because of inflammation or it's because of airflow obstruction. In fact, you can't really have symptoms of asthma unless there is inflammation or the airways are tight, there's airflow obstruction. And one of the key things you must always think about when you see the patients who are symptomatic is where are the symptoms coming from? Is it inflammation? Is it obstruction? Is it both? And if it's neither, you have to think what else is causing the symptoms. The most common reason, though, the patient's symptomatic, when they actually have symptoms due to asthma, is because of problems with adherence and problems with inhaler technique. And this has just jumped across the screen. It's possible to get to the back. So, thank you. And adherence, making sure the patient's actually taking their treatment and using it correctly, is by far the most common reason why a patient appears to have severe asthma, but actually doesn't have severe asthma at all. And this is the number one thing to always check. Now, all these things, now this is, just to highlight this point further, this was a study from the Netherlands and Holland, and this showed the proportion of patients that were on high-level treatment in a very large population study in the Netherlands. 24% were on Genostep 4 or 5. 17% were poorly controlled despite that. But actually, when adherence was corrected, when inhaler technique was corrected, all you were left with was 3.7%. And those are the ones that actually have severe asthma, even though you start at 24%. So this is the number one reason, number one cause of symptoms in an asthmatic. Now, all of this then we think of as difficult asthma. Symptoms either because it's not asthma at all, or because of other causes in an asthmatic, or because of adherence or inhaler technique. And then what you're left with is severe asthma, where you've excluded those things. They are taking a treatment every day. You've checked that taking the treatment every day. Don't just believe the patients. And you've seen them use their inhaler properly, and their technique is good. And then we use biomarkers and airflow and spirometry to tell us what is the dominant cause for their symptoms. FeNO and blood eosinophils, I'm going to talk about in a little bit. These are extremely helpful biomarkers, really, really helpful to tell us, are the symptoms due to inflammation? Because these tell us about risk. In patients that don't have high levels of inflammation, they're not actually at high risk. They don't have frequent exacerbations, they don't end up in intensive care, and they're not at risk of death. Whereas the converse is true. In patients that have high levels of eosinophilic inflammation, with high blood eosinophil counts, high levels of exhaled nitric oxide, those are the patients who are at high risk. Now, when these are normal, as I said, that's when really we have to think about what else has been missed. And that's why a multidisciplinary team within a severe asthma clinic is so critically important, because there needs to be the expertise from No, it's not forwarding. Go back now. Okay. There needs to be the expertise from the multidisciplinary team to help diagnose some of those comorbidities, the physiotherapist to help looking at the dysfunctional breathing pattern, the voice and language therapist, speech and language therapist, or ENT to really look at the larynx. Sometimes, sleep studies sometimes. Now, when you see a patient and they've definitely been taking their high dose in ICS, and they're taking it properly, and they're taking it every day, and they still have high blood eosinophils, high FeNO, those are the patients we think of for biologic therapies, because the only option for them is prednisolone otherwise. They have inhaled steroid-resistant T2 inflammation, eosinophilic inflammation that's resistant to inhaled therapy, and that by definition really is what severe asthma is. But also we see patients that have very severe airflow obstruction, similar to COPD, who maybe for 20, 30 years had uncontrolled inflammation in their airway, and they're through a process of remodeling, the airways slowly become tighter and tighter, and it becomes fixed. Now, those patients may not have any airways inflammation now. They're on a high-dose ICS. That inhaler is enough to control the inflammation, but they still have tight airflow obstruction because it's irreversible, and they will have symptoms due to that. So you can have symptoms that is only due to asthma because of airflow obstruction, but those patients don't respond to steroids. And all you do when you see a patient who's symptomatic due to airflow obstruction when they have no inflammation is poison them with steroids if you give them too many steroids. So it's really important for those patients. It's almost, you take more of like a COPD view. You maximize bronchodilation with the antimuscarinic and pulmonary rehabilitation to increase their exercise capacity and their level of conditioning. It's really important to remember that most patients with asthma sit along this line here, where as the inflammation increases, so the symptoms increase. And this is why, the personalized asthma action plans that says, when your symptoms increase, you increase this, it works if they sit along this line. But there are some patients that sit here, where they have very, very high levels of symptoms with no inflammation. And these are the ones, again, where you really need to think about what is causing the symptoms. Because if they don't have bad airflow obstruction, if the FEV1 is like 80%, 90% normal, their symptoms must be due to something else. Obesity, reflux, all those things we spoke about. And there's a third group that are really important, and these ones sit down here. And these are the ones that generally, when I go to intensive care, these are the patients in intensive care. Because those are patients that have a lot of inflammation, but they don't know that it's there. They have relatively low levels of symptoms until suddenly it's too late. They catch a rhinovirus or something, triggers a huge exacerbation, they end up in intensive care. And these patients often are not adherent to their inhaled steroids. And they're not adherent because they don't have symptoms every day. And human nature is you don't take a treatment if you don't have symptoms. That's human nature. We have to accept that. We just have to encourage our patients to use it, but we also have to realize that it's not possible for most patients. And what then this is shown, this is patients who died of asthma. About 5 years ago, the Royal College of Physicians in London carried out a national review of asthma deaths. So they looked at all the people who died of asthma. And they looked at how many inhaled steroid prescriptions in the last year those patients who died had. And what you can see is that most patients who died only picked up 2, 3, 4, 5 inhaled steroids in the last year. And you all know that if you're actually using your inhaled steroid every day, it lasts 1 month. So you should, if you're using a treatment every day, be having 12 in 1 year. So most patients who died were non-adherent. In fact, very few who actually had 12 ICSs in a year or more were dying of asthma. Then it comes on to which patients to refer. Now, there's an international program called Precision, which is funded by AstraZeneca, but is totally brand agnostic. There's nothing promotion. It's all about improving the quality of asthma care around the world. And in each country, there are different challenges that face that country in terms of why certain patients are not being referred to asthma specialists. And this is a guide, really. I don't know how well it projects on the screen, but it's a guide to who might need to be referred. So on the left here, we've got the patients who, in the last 12 months, since the last change in care, whether they've had any of the following. So at the top it says 1 or more ICU admissions, 2 and more emergency attendances, or 4 or more courses of prednisolone in primary care without needing to go to hospital. Now, if any of these are yes, automatically these patients should be seeing a specialist in secondary or tertiary care. If it's no, but they have had at least 1 exacerbation requiring prednisolone in the last year, then the next thing to ask is, are they adherent? Checking their prescription record if possible, and checking their inhaler technique. Because if either they're not taking it every day, or they're not adherent, or their inhaler technique's bad, those patients don't necessarily need to be sent to a specialist. They just need those things corrected. But if those things are corrected, and they are taking their treatment every day, and the inhaler technique is good, we're now in the last column, because the question then is, what treatment step are they on? If they're only on step 1 to 3, you just need to increase the step. Whereas if they're on step 4, those patients, again, need to be referred to a specialist. Just going to pass on this. Now, the next thing I want to talk about is the concept of first doing no harm. This was, of course, Hippocrates, the father of medicine. At the core of what we learn at medical school, as I'm sure you all appreciate, is before we do any good, at least don't do harm to your patients. And this is where the need for steroid stewardship comes in, and how we can use inflammation markers to guide us with this. Now, most of you appreciate that there's been a lot, certainly in the UK, a lot in the media and the newspapers around this concept of antibiotic stewardship. The idea that, there's around the world, there is an increasing risk of antibiotic resistance. And this is the NICE document that was published 4 years ago on the website. And this is really in the context of all these newspaper reports, which these came secondary to all their actual journal publications, really highlighting a major, major problem around the world in terms of antibiotic resistance. And this really comes from, it's our fault as doctors, because someone comes in with a runny nose, you've got a virus, and you give them antibiotics, we give them antibiotics inappropriately. It's patients' fault for only taking 1 day or 2 days and stopping when they feel better. But it's a major problem. And the same concept we need to think about with steroids. So if I go back to that NICE document, I know it's small print, but essentially this is what it says, and it gives about recommendations for prescribing antibiotics, antimicrobial. And we can just cross this out actually and put OCS, oral corticosteroids, prednisolone. Because the same things apply. The top thing there is when prescribing antimicrobials, prescribers should use the shortest effective course. Now, this is really about the importance of limiting these prolonged weans of prednisolone. Often, if someone doesn't have inflammation, they don't need, long courses of pred where you reduce by 5 milligrams every week or something like that. It's 1 week is enough, 5 days is enough if the inflammation's already been treated. Important to check they're adherent to inhaled steroids before putting them on prednisolone every day. Don't assume it's the case. This point here about consider point of care testing in primary care for patients with lower respiratory tract infections. Point of care testing in antibiotics in asthma really is about biomarkers using eosinophils and FeNO. And again, down here, where it says prescribers should take time to discuss with the patients why prescribing antimicrobials may not be the best course of action, maybe not be the best option here. That's really about this concept of T2 low asthma, this non-eosinophilic asthma. The idea that if you don't have inflammation, prednisolone is not going to help it. Like if you don't have hypertension, giving someone an antihypertensive doesn't do anything. And finally, what is on this is about this concept of alternative options for the antimicrobial. And similarly in asthma, this is really about the biologics. Now, we know steroids work. They're very, very good. This was a Cochrane review from 2001, just showing that steroids shortened admissions, it reduced the likelihood of being admitted to hospital, and so on. But they come at a cost. And this is David Price's paper, really huge numbers of patients, looking at the hazards ratios, the odds ratios of all these complications associated with steroids. And this is looking at the risk when you have systemic steroids versus not systemic courses of steroids. Osteoporosis, pneumonia, a long, long list. But what also comes out is it depends on the dose. And this is from the same study. And if we just take, for example, osteoporosis here in the middle, and over here we see the triangle is if you're on more than 7.5 milligrams per day, here is between 5 and 7.5 milligrams a day, and over here is 2.5 to less than 5 milligrams per day. And you can see for osteoporosis, the odds ratio of if you're on 7.5 or more, 10 milligrams a day is like 14 now. So there's a dose response with how much steroids you give a patient. But it's not just systemic steroids. So this is a really important study from last year that shows that even 4 separate courses is enough to increase the likelihood of all these complications. This is osteoporosis, hypertension, obesity, diabetes. It increased the odds ratio of all these complications. This is 4 separate courses in 1 year. And what the study also showed was that every year of having 4 courses increases that odds ratio further. And it's also associated with death, steroids. So this is a study in rheumatoid arthritis, but the same applies to asthma. And what it showed was all-cause deaths. This is related to steroids because they've taken into account all the potential confounders for death. And for cardiovascular deaths over here. And they've shown in different ways of showing it, milligrams per day or grams per year over here. So think of it, every gram that goes up, your odds ratio, your hazard ratio goes up further of death. This is not osteoporosis, this is actually dying of the complications of steroids. So we have to really move away from just handing out steroids like they're safe and everything's fine, it's not going to do harm to your patients. Yes, they work, and they're still important, obviously, but it's important to use them appropriately in the right patients, because like all drugs, they're potentially associated with risk. And coming back to Hippocrates here in Latin, this was what he originally said, first do no harm. And it's our job as physicians to make sure we're not actually doing more harm to our patients than good by giving them to patients that may not need them. And we've known now for a long time, this is the Lancet paper from 1958, 61 years ago. This English physician called Harry Morrow Brown in the Lancet. And what he said was in this paper was that if you had eosinophils in the sputum, prednisolone worked. And if you didn't, it didn't work. So this whole concept of using biomarkers like eosinophilic inflammation to help us guide us to who we need to give systemic steroids to is not something new in the last few years. This has been going on a long, long time, but unfortunately it was forgotten about. And this brings on to the concept of asthma phenotypes. The idea that some patients have this inflammation, some patients don't. So broadly speaking, the current asthma paradigm, although it's really changing very quickly and it will continue to change in the next few years, is that for the last 10 years at least, people think that asthma has been divided into 2 groups. The patients with T2 high or eosinophilic inflammation, the patients without it. You either have it or you don't. And if you have it, it's associated with more severe asthma, with responsiveness to steroids, and so on. And if you don't have it, it's less severe. And it's the patients that don't have it, the inflammation is in line with what healthy people have. So let's think about this T2 inflammation, this Th2 inflammation. Now this is a very busy, complicated slide. You may have been shown it already today, but for the doctors in the room who are not respiratory physicians or not familiar with the immunology of it, just to really guide you in terms of the 2 main phenotypes of asthma within T2 high asthma. What it shows here is on the top, you've got your airway epithelium, the lining to the outside world. And that epithelium is exposed to various triggers like allergens and viruses and pollution. And it causes the airway epithelium, the lining, to become immunologically active. And dendritic cells, which is these blue cells here, sample the environment, get the allergen, and then present it to naive T cells. And in patients who've got allergic phenotype, those naive T cells polarize into Th2 cells, which produce the classic Th2 cytokines of IL-4, which is the most important cytokine that tells B cells to make IgE. IL-5, which is the most important cytokine that tells the bone marrow to make eosinophils and increases the activation state of eosinophils, delays apoptosis of eosinophils. And IL-13, which is the most important cytokine for airway hyperresponsiveness, mucus hypersecretion, and airway remodeling. Now, as you can see, the eosinophil here is in the middle, because you can get to airway eosinophilia either through this classic allergic way, where there's the Th2 cells, or without any inflammation at all through the innate pathway. So this is adaptive immunity. On the right is innate immunity. And the type 2 innate lymphoid cell, the ILC2, appears to be the most important cell here, which also produces enormous amounts of IL-5 and IL-13 without anything to do with allergy. So you can have eosinophilic inflammation, T2 inflammation in the context of allergy or without. And we see that when we look at blood eosinophil counts across a huge population in primary care in the UK of 60,000 patients, that the higher your blood eosinophil count, shown here, is 200 to 300 and so on, the more likely you are to experience a severe exacerbation, and the less likely you are to be able to control your asthma. So there's a clear dose response between your level of eosinophils and your risk and your day-to-day quality of life and symptom control. And again, this is not something new. This is 1975 in the New England Journal of Medicine. This is a line from the abstract that reads, the total eosinophil count reflects asthmatic activity, is useful for regulating steroids, and for early detection of exacerbations in 1975. And then about 15, 16 years later, in, 25 years later or so, in Leicester, Ruth Green did a study with Ian Prevord where they, based on this concept, they decided to make a decision on the management of the patient, either based on symptoms or based on inflammation. So you can see that the solid line over here is where the decision to increase or reduce therapy was based on symptoms. That's the BTS management group. Whereas this line were the patients where it didn't matter how symptomatic they were, treatment was increased or reduced only based on whether you had sputum eosinophils or not. And by doing that and making a management decision based on objective evidence of inflammation rather than symptoms, it led to a 50% reduction in exacerbations. But sputum is really difficult. And what, fortunately, the blood eosinophil count tells us is very similarly, if you look over here, so this is patients who had simultaneous blood and sputum eosinophil counts measured. And what you can see is if you had a blood eosinophil count of 300, so 0.3 or more, virtually every single patient, apart from maybe that one down over here, had significant airway eosinophilia, sputum eosinophilia, which we think of really as 3%. So an eosinophil count of 300, 0.3, is very indicative of airway eosinophilia. But it's also important to remember that there are patients over here that have significant airway eosinophilia that actually have a blood eosinophil count that's lower than 0.3, 0.3. So just because your patient has an eosinophil count lower than that, it doesn't mean they don't have eosinophilic inflammation. And that's why FeNO, exhaled nitric oxide, is a very useful biomarker to use with blood eosinophils, because often it captures some of these patients over here that you might miss otherwise. Now, FeNO is, I don't know how many of you have FeNO. Just put your hands up if you've ever used FeNO, just so I have an idea about it. Okay, so the minority. FeNO is a machine, very small, really easy to do, that measures nitric oxide, which is produced by the airway epithelium. And it's produced when you have IL-13. Because when you have IL-13, this enzyme, nitric oxide synthase, produces nitric oxide. If you don't have IL-13, it doesn't really get produced in significant levels. And so it tells you about IL-13 levels. It doesn't tell you about eosinophils, but it tells you about IL-13. But the reason it's relevant is because if you have nitric oxide high levels, that means you must have high IL-13, which means you must have the cells that produce IL-13, which are the same cells that produce IL-5 and eosinophils. And in the same way as we showed you that paper before of making a decision based on sputum eosinophils, this is a similar study where they used FeNO in the same way. And what they did here was they took 220 pregnant asthmatics. And they chose pregnant asthmatics because this is often, as I'm sure you appreciate, a group of patients who are quite difficult to manage when they're symptomatic. Because it could be difficult to know, are the symptoms due to asthma? Or are they due to the uterus pushing up the diaphragm? Or are they due to reflux getting worse because of the pregnant state? So it's very difficult sometimes to know. And by using a biomarker of inflammation, it helps guide you as to whether the symptoms are likely to be due to asthma or likely to be due to something else. And again, what they did, the authors, is randomize patients to either increasing or reducing inhaled steroids or prednisolone based on symptoms, which is the green line, the control group, or based on the FeNO level. And when they did that, again, they ignored symptoms. If you were in the red group, the FeNO group, it didn't matter how symptomatic you were. Your treatment was not increased unless you had inflammation. And when they did that, again, they halved all the exacerbations. And this is despite also leading to a reduction in the amount of inhaled steroids on average they were on. So this is, I know it's small here, it's difficult to see. This is the dose of ICS here. So they needed less and still had a halving of exacerbations. One of the things to remember about this dichotomy of asthma into T2 high and T2 low is that many patients sometimes don't have T2 inflammation and other times do. So it's not a constant phenotype. So you might see a patient over here in clinic. This is showing, let's say, the blood eosinophil count over a year. And you could see them here and they look non-eosinophilic. They look normal. But actually, a month later, in the context of a virus, they've got very high levels of eosinophilic inflammation. Or a few months later, in the context of their hay fever they have. So just because you see a patient here, don't fall into the trap of mislabeling them as a non-T2 patient who's never going to need steroids and never going to potentially benefit from a biologic. And I think this message comes through in this publication. And this here, what they did here was to look at the sputum inflammatory phenotype when the patient was stable compared to during the exacerbation. And if we just look at the stable state firstly, what you see is that about half the patients didn't really have any significant inflammatory cells above normal at all. 17% were eosinophilic. There was a further 5% that had eosinophils and neutrophils, and then a proportion that had neutrophils. So about 25% had eosinophils either alone or with neutrophils. But when you saw the patient during the exacerbation, actually 50% were eosinophilic, and a further 36% were also eosinophilic, but they also had neutrophils. So 86% now had eosinophilic inflammation in the context of exacerbation. And this is why we still see very, very good responses to some biologics, even below that cutoff of 0.3 or 300 cells. The exacerbations, if they are genuine exacerbations of asthma, are still mediated by T2 inflammation in that way. But of course, when, one of the problems with the literature about T2 low inflammation or the absence of inflammation is the effect of steroids, which often is not taken into account. And so this is just to highlight this point. This is a bronchoscopy study where they looked at eosinophils here on this graph and neutrophils here. And what they did a bronchoscopy 1 month before and after high-dose ICS. Okay, so these patients were not on ICS. They did a bronchoscopy, then they gave them high-dose ICS, and then they did a bronchoscopy again. And what you can see is when they sampled the peripheral airways or the central airways, that the eosinophils go down and the neutrophils go up. And that's what steroids do. That's why they work. I'm going to just skip through this one because it's not going to add anything. Go back to here. And this was, No. This is earlier in the year, just to show the effect of increasing treatment now from medium dose to high dose ICS on blood eosinophils, showing that it leads to a reduction in inflammation just from going from medium to high dose. So what happens is often we see patients who are symptomatic despite treatment, and they're uncontrolled, and their treatment gets increased to high-dose ICS, or they start prednisolone. Now this, as I've showed you, leads to a reduction in eosinophils and an increase in neutrophils. But what it also does is it impairs host defense. It infects your immunity against infection in the lung. And this then leads to chronic airway infection. You see this very often in asthma, this chronic bacterial infection or recurrent infections. And this, of course, also leads to an increase in neutrophils. And at the same time, it increases your likelihood of bronchiectasis, which in turn increases the likelihood of chronic infections, which lead to ongoing symptoms. And it goes round and round and round in this way. And what we're left with are these labels of T2 low asthma, non-eosinophilic asthma, neutrophilic asthma. But at the heart of all of these labels, in reality, is the effect of steroids and the damage steroids do by increasing inflammation, increasing infection in the airway and recurrent infection. The last point I want to talk about is the biologic therapies in severe asthma. And we're very fortunate now over the last 10 years to have increasing numbers of these biologics that have really totally revolutionized the care of our patients who before were totally dependent on prednisolone in the most severe patients. Now all the biologics now target different aspects of these pathways. So omalizumab was the first to come out over here, which targets IgE. And then we had mepolizumab, which we started using in the UK almost 3 years ago now, which targets the IL-5 cytokine. It's a serum neutralizing antibody against IL-5. Then we had benralizumab, which targets the IL-5 receptor, which is expressed on eosinophils and basophils and eosinophilic precursors. And then more recently, we've had now dupilumab, which targets the IL-4 receptor. And the IL-4 receptor is important is necessary for signaling of both IL-4 and IL-13. And this first was used in eczema. It's got a license in eczema. It's also recently been FDA approved for nasal polyposis. And then in phase 3 studies, we've got tezepelumab, which targets TSLP. This is probably going to be the most effective drug of all the drugs so far because it's high up, it dampens down all the cytokines, including IL-4, 5, and 13. And so you see levels of IgE going down, you see levels of eosinophils going down, you see levels of FeNO going down, representing IL-13. And you've got CRTH2 antagonist called fevipiprant. That's in phase 3 at the moment, going to read out later this year or next year. It may or may not be successful. I worry that the phase 3 actually won't be successful with that. So omalizumab, we've been around the longest. And this was the first randomized control study where the patient actually had severe asthma, according to the Cochrane Review. So this was published in 2013. And here there were 850 patients approximately who were randomized to either omalizumab or placebo. Now, overall, there was a 25% reduction in exacerbation. But in the patients on the high-dose ICS LABA, the rate ratio was 0.66, so there's a 34% reduction in exacerbations in that group. In the patients on ICS LABA plus another controller, which was normally montelukast, there was a 28% reduction in exacerbations. But in the patients on maintenance prednisolone, which was 140 patients here in this group here, M3 OCS 73 and 71, omalizumab didn't actually work. It didn't lead to any reduction in exacerbations or any clinical benefit at all. And this is an important point because what we're finding is omalizumab works in certain patients with T2 inflammation who are having recurrent infections, recurrent viral infections. But if your asthma is so severe as to need prednisolone every day, in our experience and from controlled studies, it doesn't actually work as well. And this was a real world study from the UK, essentially highlighting this point. So this was published 3 years ago. A large number of 250 patients approximately on omalizumab. And they looked in this graph at the patients 1 year before and 1 year after omalizumab and how much prednisolone they were on, the patients on maintenance prednisolone. And what you can see is although there was a statistically significant reduction in prednisolone from around 15 milligrams to 13 milligrams, in reality, it was a tiny reduction clinically, despite the drug. And when we look at large, real-world studies, again, this is the largest of them. This is from Japan, almost 3,000 patients. Again, the top line is exacerbations the year before omalizumab to the year after. And what you can see is each color represents the number of exacerbations. So blue is they've had 0 exacerbations, red 1, and so on. But what you can see is that almost half of the patients were still having at least 2 exacerbations on omalizumab, highlighting the fact that there is still this great unmet need. And these are the allergics, severe allergic asthmatics. This is obviously the severe non-allergic asthmatics were already that unmet need. But within this allergic asthmatics, it's still a major problem. And so when mepolizumab first came available, it really was a huge step forward for us looking after these patients, because for the first time, we now had a drug that could, number one, treat the non-allergic severe asthmatics, but also some of the severe allergic asthmatics who are still struggling. And what you can see on the right is a post-hoc analysis of mepolizumab, really showing that as the more eosinophilic you are, the better you do. And if we look at this as a continuum, this is the benralizumab data, which is the anti-IL-5 receptor drug. You can see the black line is placebo, the green line is benralizumab. Here is the exacerbation rate on this axis, and this is as your blood eosinophil count increases. And this is a pooled analysis of the 2 phase 3 studies for benralizumab. And what you can see is, if you're given placebo, the more eosinophilic you are, the higher your exacerbation rate. But if you're given benralizumab, that doesn't increase at all and actually reduces the more eosinophilic you are. What's interesting is if we do the same thing for IgE. So this is now IgE, the same group of patients. Again, what you see is that as your IgE goes up along this line, your exacerbation rate, given when you're given placebo, actually doesn't increase. And it doesn't matter how high your IgE is, if you're given benralizumab, your exacerbation rate stays stable. And this highlights a very, very important message, which is what appears to come out from the benralizumab data, from the mepolizumab data, is that it doesn't really matter whether the eosinophils are in the airway from the allergy side or the non-allergy side. If you can take the eosinophils out of the airway, the patient stop exacerbating. So the idea that you may go by where if the patient's allergic, you give them omalizumab. If they're not allergic, you give them mepolizumab or benralizumab, is not actually evidence-based. The reality is, if you can remove the eosinophils from the airway, it doesn't matter how allergic you are, you do exactly the same. And just to show you this in a different way, this is the mepolizumab post-hoc analysis. And on the right, you can see, according to the seasons, where if they split all the patients into either atopic or non-atopic over here, placebo is the black line, mepolizumab is the open circle, the patients did just as well whether they're atopic or non-atopic. And again, in the same way as I've just shown, if they took all the patients and divided them on their IgE levels into quartiles, the lowest quartile had an IgE of less than 70, the highest quartile had an IgE of more than 430, but the exacerbation risk reduction, the rate reduction was exactly the same. It was basically half. It didn't matter whether you had an IgE of less than 50 or more than 500, it was the same. And again, when we do the same thing in quartiles with benralizumab, we see exactly the same thing. Green here represents the exacerbation rate on benralizumab. Your IgE here, that the quartile was less than 62, and the highest quartile was over here, greater than 450 approximately, but the numerically is exactly the same exacerbation rate. This is a very, very busy slide because this was a poster I literally presented 2 days ago at the British Thoracic Society Congress, and this was a post-hoc analysis of our own cohort of patients who were having on mepolizumab and benralizumab. And what we wanted to answer was, for those patients who were also eligible for omalizumab, who had an IgE in the right range, they were sensitized to a perennial allergen, they had the right weight and the IgE for them to be dosed, how did they respond when we gave them mepolizumab and benralizumab? So I'm not going to take you through all this information, but this is just the baseline characteristics on the left, the patient's eligible for omalizumab and the patient's not eligible. And here are the secondary outcome measures. Again, the patient's eligible or not eligible for omalizumab. And the take-home message is that the reduction in exacerbations, the reduction in prednisolone, change in asthma quality of life scores or asthma control was exactly the same. It made no difference whether you were also eligible for omalizumab or not on how you did when we gave you benralizumab or mepolizumab. So atopy doesn't make a difference in terms of response to biologics, unless of course it's omalizumab where if you're not atopic, it doesn't work. But there are certain factors that really indicate a better response to a drug like benralizumab or mepolizumab. And these are shown here in this post-hoc analysis of benralizumab. So over here you see OCS use. On the top is exacerbation rate. At the bottom is change in lung function. And the columns are really, is yes or no, are you on prednisolone every day or not? Do you have nasal polyps or not? Do you have very poor lung function or not? High exacerbation rate and so on. Adult onset. And what you can see is the factors most associated with a superior response to these drugs are the need for prednisolone, nasal polyposis, high exacerbation rate, adult onset, and so on. Now, it doesn't mean that if you don't have these, it doesn't work. It's just that these are the things that in particular are associated with a good response. And just to look at the phase 3 data for the steroid sparing, because these are patients, these are really the most in need patients, the unmet need, the ones who are needing prednisolone every day. And this is the benralizumab data. And this, of all the steroid sparing studies, is the most impressive in terms of the number of patients who could come off prednisolone completely, which was half the patients. And despite that, there was a 70% reduction in exacerbations. So really, really impressive results. So what about the last biologic that we're going to talk about, dupilumab? Now, dupilumab has just become available in the UK for asthma. And as I said, is already used for eczema. So the data for dupilumab from the phase 3 studies is very good, but they had one major problem. And that was they had a huge placebo effect. Unfortunately, they didn't recruit patients who genuinely had severe asthma. Because when those patients went into the clinical study and started using their inhaled therapy properly, suddenly they stopped exacerbating and their lung function jumped up a lot. And you can see the lung function down here. Whoops, sorry, let's go back. The lung function down here on the bottom left, this jump of 200 mils is all placebo. That's just taking their inhalers, their normal inhalers. This is the effect of dupilumab above that. Again, here the exacerbation rate initially was 3 or, and then when they're given placebo, it jumped down significantly. But the thing about this drug, dupilumab, is it's in the same way as mepolizumab and benralizumab. It only works if you're eosinophilic. So this is the blood eosinophil counts here, less than 150 or 150 to 300, more than 300, and the ratio of success. It doesn't work if you're not eosinophilic. So it's the same group of patients in reality. Now, they also talk about FeNO. FeNO wasn't measured in the mepolizumab studies. It wasn't measured in the benralizumab studies. But I can tell you from our own cohort, it would have been exactly the same. The higher the FeNO, the more likely you are to respond to mepolizumab, the more likely you are to respond to benralizumab. This is not specific to dupilumab. It's just that they didn't measure it in those other studies. But what comes out is exactly the same trend. If you have T2 high inflammation, you respond to these drugs, all the drugs, omalizumab, mepolizumab, benralizumab, dupilumab. If you don't have T2 inflammation, you don't. Again, this is the steroid sparing study for dupilumab. Just look at this placebo response over here on the right. This is reduction in prednisolone every day. The red line is placebo. What this really highlights is what I was talking about earlier, which is stewardship of steroids. What this shows is that those patients were being given steroids by their doctor, and when they were reduced, it didn't make any difference, which means they didn't need them in the first place. There was a 50% reduction when the patients were given placebo. which means the doctor was giving them 50% more prednisone than they needed. So I'll just summarize what we do with biologics in our center in the UK. The first message is, of course, is prednisolone is toxic, okay? If there's one thing I want you to come away with is remembering this point and the need to use biomarkers to try and optimize therapy, okay? It's absolutely critical to use these biomarkers. Now, we use omalizumab in patients who have child onset disease, who are polysensitized, but really we choose it if patients, specifically if they have comorbid urticaria. As I'm sure you appreciate, omalizumab is a brilliant drug if you've got urticaria. But if they need maintenance prednisolone, then we wouldn't use omalizumab first line because it doesn't work as well as the IL-5 drugs. Similarly, with in terms of comorbidities, we use dupilumab first line if they have severe eczema, because it's an excellent drug for eczema, and so they can have one drug that treats both. If they don't have severe eczema, they don't have urticaria, but they have T2 disease, we use benralizumab first line. And we use benralizumab first line rather than mepolizumab first line because, number one, it's every 8 weeks compared to every 4 weeks, which for our patients is a significant benefit in terms of time off work and so on. And also some of the phase 3 studies in terms of the exacerbation rate on the treatment is lower. And we've seen better effects with benralizumab compared to mepolizumab in that group. But otherwise, if someone's having, so we would use mepolizumab in someone who's, for example, had side effects to benralizumab, or if there's been developed antibodies to it. There's about 10% of patients from the phase 3 studies and our own cohort as well who do develop antibodies to the drug. And so if they've otherwise done well, we would maybe use mepolizumab second line in those patients. Otherwise, we use dupilumab as a second line to benralizumab. And again, dupilumab is a fantastic drug, but it's every 2 weeks. And so, although probably most of the patients who do very well with benralizumab, mepolizumab would also do very well with dupilumab, when we have a situation where I can say to the patient, look, I've got this drug A, it's every 8 weeks, or drug B, it's every 2 weeks, both of them probably are going to work very well for you. As the patient, you obviously, it's better for the patient to have something that's every 8 weeks. And so that's why we use it in that sense, not because the other drugs don't work. So I'll stop there and happy to take any questions. Thank you.
Okay, thank you so much, Dr. David, for this very interesting and informative presentation. We're going to open for questions, and maybe even our colleagues in Jeddah and Dammam can at the same time ask questions. So let us see. Yes, please, go ahead.
Yes, I'm Dr. Mohammed
Can you
Shahid
raise your
Akhtar.
voice, please, and say your
I
name?
am Dr. Mohammed Shahid Akhtar from Riyadh. My question is, what is the treatment of non-atopic patients, T2 low asthmatic patients?
So the treatment of non-atopic patients and T2 low patients. Is that the question? Yeah. So the non-atopic patients, the first question, which I always try and ask myself with a patient in front of me is, do they have inflammation despite their high-dose inhaled steroids? If it is, then they need a biologic, okay? And what I've hopefully tried to demonstrate is at that point, whether or not they're allergic, they respond probably better to an anti-IL-5 type drug than they do to an anti-IgE drug based on the phase 3 data, okay, and our own experience. Okay. If they don't have T2 inflammation, omalizumab, even if they're allergic, if they don't have T2 inflammation, omalizumab doesn't actually work. And in the post-hoc analysis by Nick Hanania that he did on the phase 3 studies, what it showed was that unless you had a FeNO above 20, unless you had a blood eosinophil count above 260, omalizumab didn't work. So you have to at least have, it's not good enough just to have an IgE of 300. You actually need to have inflammation that is not controlled on the inhaled steroids for a drug like omalizumab or any of the biologics to work. In terms of the non-T2 patients, critically there, it's trying to understand, are the symptoms due to just airflow obstruction? Just like a COPD patient is breathless every day when they walk far and they go upstairs and so on. And for those patients, steroids do nothing but damage. And for those patients, as I've said, it's really about maximizing bronchodilation with an antimuscarinic, pulmonary rehabilitation and an exercise program. And if they are exacerbating, it's trying to understand what is that exacerbation. And it's very, very helpful to try and get a blood eosinophil count during the exacerbation to understand, is it something that is the T2 inflammation, which would need prednisolone, or is it a bacterial problem that might just need antibiotics? In the same way as, many COPD exacerbations just need antibiotics. They don't necessarily need steroids. And again, so it's really...
David, we have some more questions.
Yeah, sure.
So please,
Yeah.
Conclude.
Yeah. So yes, that's the key. Is the symptoms due to inflammation, obstruction, or is it due to bacterial infection that might need antibiotics in the T2 low patients?
Okay, I think there's a question from the mom. Yes.
Thank you, Dr. David. I would like to ask, are there any benefit of combination of two biologic on treatment of severe asthma, i.e. anti-IgE or interleukin 4 or 5?
Yes. So it's an important question. I think if biologics were very cheap, using two biologics together would be more of an option. But what I would say is that I think if biologic number one doesn't work, it's better to stop number one and then start number two rather than adding to number one. Because if you, let's say you're on omalizumab and it doesn't work, and you think, all right, let's add in mepolizumab or benralizumab, and it does work. Now, you don't know then whether you need two or whether actually all you need is mepolizumab or benralizumab. So it's much better to, with all medicines, if it doesn't work, stop and then try something else rather than combining it, because what we know is often if you combine, patients will get more and more medicines and suddenly they've got this bag of 50 medicines and really they don't need half of them and they only need the ones that actually work, but they just keep on getting added. So my advice would be always to stop and try something new rather than add it together. But there's no data yet on anyone who's using two biologics simultaneously, really. No published data anyway.
Maybe the question from Jeddah this time. This is your turn. Any questions? Okay, there's a question again from the mom. Please go ahead.
Yes, good afternoon. My question, would you ever consider to stop these biological treatments? Let's say, like other asthma medications, if patient has been controlled for good time, since these medications are expensive. When would you consider, if ever? If you ask the companies, the pharma, they would say never. Patient is severe, just keep them for life. But I don't think that's the answer.
Yeah, it's a really important question. The short answer is we don't know, because these drugs haven't been used for long enough to know whether they are, they can be stopped. We know that the drugs aren't disease modifying. Okay, so if they can be stopped, it's because the patient's asthma has just evolved in the normal way that patient's asthma does. The natural history of asthma changes over time, and maybe it becomes less severe, and so they don't need it. Now, we know there was a study in omalizumab from America, where after 7 years, patients were randomized, either continue omalizumab or stop omalizumab, and it was blinded, they didn't know. And what that study showed was that about half of the patients that were stopped didn't exacerbate at all in the year that followed, showing that they could be stopped, whereas the other half did exacerbate. And the key factor that identified the patients that were at risk of exacerbating was T2 inflammation. So the ones that had a blood eosinophil count of 0.3 when they were on omalizumab, those are the ones that were more likely to exacerbate when omalizumab was stopped. Whereas if they didn't have any evidence of T2 inflammation, when they were stopped omalizumab, they were fine. So I think if you have, this is for omalizumab, there's no data for mepolizumab or benralizumab. But, and again, I guess it depends on what how severe the patient's asthma was before. I think the kind of patient who really needs prednisolone every day or is having, you know, one exacerbation every month that is really high eosinophil counts, probably they may not be able to stop it for many years. Whereas the kind of patient that's only having 3 or 4, maybe their adherence to inhaled therapy wasn't so good, it's possible that you could try stopping it and see. But we don't know. It's a totally evidence-free zone at the moment with regards to that.
Thank you. Any other questions from here? Okay, I just have one other. When we start to use omalizumab, we face with patients who have the IG in the thousands, and we couldn't attribute this to asthma or parasitic infection. What do you do? Because even the limitation for the criteria for use of omalizumab with the range of IgE very high. So what do you do in this case?
So it's a common problem. The 2 most common reasons why an IgE is over 1,000 is either because of eczema or because of fungal sensitization. Those are in our clinic, those are the most 2 common causes. So a patient with eczema commonly has an IgE of 5,000, 10,000 just because of eczema. Nothing to do with the asthma. They've got asthma, but it's not, the IgE is eczema. Whereas if they don't have eczema, then in our experience, it's because they're sensitized to a fungus. Usually it's Aspergillus or Penicillium or Candida, and they're kind of on the ABPA spectrum. Now, as you said, we can't give omalizumab to those patients. At least in the UK, we can't because there's a specific dosing table. And we use anti-IL-5 drugs in those. And as I showed with the one chart with the benralizumab, on IgE up to 2,000, it was exactly the same, the effect size. I presented at ERS some dupilumab data, also a post-hoc analysis of their phase 3 program. And they also, dupilumab is excellent in patients who have an IgE of 2,000, 3,000, 5,000. It works very, very well in that group. But I think what's really important to understand is that IgE because of sensitization in the lung, or is it actually just the eczema? I think that's in a patient that has eczema, that's sometimes difficult to know. So in our experience, the IL-5 drugs work well with the high IgE, and dupilumab does as well.
Okay, with this, I'd like to thank you again for the excellent presentation. Okay, maybe last question there. Go ahead, please. Can you come over here just for the camera?
Okay, thank you very much for giving me this chance. I thank you very well for this extensive presentation of this new biologics coming up. Now, my question is that we are so much worried, and has been said yesterday and today, that we are worried about the cost. But can we have a look at it that this cost at the end, if a patient gets severe asthma or gets severe exacerbation, he will go to the ICU. So what is the cost of the ICU compared to is there any research or any evidence to show the cost effectiveness of applying these biologics in practice?
Yeah, so it's a really important question. So in the UK, we have NICE, which is the National Institute of Clinical Excellence, and they are a health economic body, and their job essentially is to do the health economic argument about this. And what is clear is, within a hospital, intensive care is by far the most expensive place. 1 week on intensive care in the UK is about £100,000. So which is going to pay for, depending on how much the biologic costs in your country, but it's 10 years of biologics for 1 week in the ICU. So from that point of view, it makes an enormous, enormous difference. The health economic argument for the patient that doesn't go to hospital but still needs courses of prednisolone from their GP is more difficult, but it relates to the comorbidities caused by the steroids. Prednisolone is cheap, we all know that, but it's the damage that they do. The treatment for the diabetes it causes, the treatment for the fractures from the osteoporosis and the heart disease and so on. And it's more difficult to put a number on that. But what is clear, certainly from the health economic argument in the UK, is that once you cross 3 exacerbations and the morbidity from the steroids of 3 courses in 1 year, then it starts to become cheaper. The biologic is cheaper than the comorbidities at that point.
Great. Okay, I think that's the end of the session. Thank you so much, and I appreciate your help. Thank you. Please welcome. That will conclude our session. Thank you very much. Thanks everybody for attending. Thanks for all our speakers and the organizers and our colleagues from AstraZeneca and everybody. Thank you so much. Please send your evaluation and any other formalities. Wassalamu alaikum wa rahmatullahi wa barakatuh.
Doctors, please take your seats. We will distribute papers.